Good day, good morning. Can you hear me?
Yes, Luchika, at least I can hear you.
Okay, good. Thank you. Good morning. Thank you, Andrei.
Уважаемые коллеги, пожалуйста, Займите свои места. Я думаю, по времени мы уже начнем нашу конференцию.
Сейчас. Sorry.
Ассаламу алейкум, хурматли конференция катнашчылары. Доброе утро, уважаемые господа, уважаемые участники конференции. Good morning, our dear guests and member of our conference. Я рада приветствовать всех вас на 5-й международной конференции по комплексной борьбе, интегрированной борьбе с туберкулезом в Центральной Азии. Это уже 5-я наша конференция, которая началась еще с 2016 года и проходит в разных странах Центральноазиатского региона, но очень символично, что в этом году именно эта конференция проходит у нас в Узбекистане, в Ташкенте. Ситуация, которая сейчас во всем мире диктуется нам ковидом, этой новой инфекцией, вносит свою коррекцию. И наши возможности должны быть приумножены для того, чтобы мы боролись с 2 воздушно-капельными инфекциями и туберкулезом.
Airdrop infections, tuberculosis and COVID in their combination and interaction. And I'm especially happy that today we were able to get together in a narrow circle in this hall, but again, this is dictated by the COVID infection. But in online, we have more than 300 participants connected. These are our high-level international organizations such as USAID, World Health Organization, Top TB Partnership, KfW Bank, and many others. And with great satisfaction, I would like to give the first floor to the Deputy Minister of Health, Professor Sabir Ulugбек Yusuphanovich, who will make an opening remarks to open our conference. Thank you. Good morning, dear colleagues. Good morning, dear colleagues. Your Excellency Ambassador, Mr. Rosenblum, dear Liana Kupins, Dr. Dilaram Kasimovna, thank you very, very much for your participation in spite of your tough schedule that you take part in this very important conference. Dear partners and guests, for me, it's a great honor to welcome you at the 5th International Online Conference on Integrated Control of Tuberculosis in Central Asia. A uniqueness of this conference, it's a platform of new WHO recommendation on treatment of patients with drug-resistant tuberculosis and experience of introduction of the global recommendations on TB treatment in Central Asia. The overview of the activity of international partners, their achievements and challenges during pandemic of COVID. Discussion of introduction of digital technologies, TB services, electronic surveillance system over tuberculosis, pharmacological surveillance on TB drugs in Uzbekistan, overview of modern technologies and approaches in the work of the bacteriological laboratory in psychiatric institutions. This is a platform to exchange knowledge and skills and plans in order to ensure the enhancement of political commitment, financial sustainability of the national anti-TB programs, new achievements of international integration and intersectoral cooperation in resolvement of global problems of TB eradication. I would like to say that in the 3rd day of the conference, we will have a unique opportunity to learn the experience of the funding of the healthcare in Kyrgyzstan. Pediatric Service of Uzbekistan includes ideas of strategy, and TB achieved good results in reducing the deaths and morbidity cases of TB in Uzbekistan. And we have new strategic goals to develop our service, such as improvement of our legal framework, informing different structures, including development of high-tech service and palliative service on TB, introduction of the effective programs on TB prevention and diagnostic of the latent TB infections, intergovernmental interaction and ensuring the quality bacteriological diagnostics, expanding of the early identification of the sensitivity, and wide introduction of the modern technologies, application of new TB drugs, and short-term treatment modes. These goals are matching the commitments adopted on the UN level on the 26th September 2018. And as a confirmation of commitment of Uzbekistan to these goals was the signing of the MOU with between the Ministry of Health and USAID, which is focused on strengthening of the cooperation between US and Uzbekistan on overcoming the time of dissemination of the TB in Uzbekistan, especially its forms and wide drug resistance. This goal serves a new USAID program, which is called Global Accelerator. During many years, USAID is helping activities by the Ministry of Health to stop dissemination and ensure the prophylactics. Currently, we're introducing 5 USAID supported projects on TB with a total amount of $12 million for the next years. And historically, since 1993, the government of United States supported Ministry of Health for the total amount of 146 USD amount. We hope that our further cooperation with USAID and our colleagues will help promoting our general objective, which is liquidation of TB in Uzbekistan and in region as a whole. I wish success to all the participants. Thank you very, very much. Thank you, Ulugbek Yusufkhanovich. And now, with great pleasure, I would like to give the floor to His Excellency Ambassador Daniel Rosenblum. And I should say that from the very first days of the work in Uzbekistan, we started with the first TB program. We were closing one and opening another new one. But as I said, the most important is that we continue cooperating together. And I'm very happy to recognize that Mr. Rosenblum is personally participating in spite of his tight schedule. And thank you very much for visiting our conference today. Please. Thank you very much. Assalamu alaikum.
Thank you very much, Dr. Parpieva, for that introduction and for the opportunity to work together over the years that I've been in Uzbekistan. Deputy Minister Sabirov, Dr. Parpieva, Dr. Kupins, Ms. Kasimova, distinguished guests and participants in the conference. It's really my pleasure to be here today to participate in this 5th annual international conference on integrated tuberculosis control in Central Asia. As Dr. Parpieva said, we have been a proud partner for many years now in this fight against tuberculosis. And through our collaborative efforts here in Uzbekistan and throughout Central Asia, we've succeeded together in reducing the burden of tuberculosis, improving the well-being of families, and supporting the health systems that make this all possible. Recently, we joined the government of Uzbekistan and other international partners to contain and control the COVID-19 pandemic, our latest challenge. The United States Agency for International Development leads the US government's global TB efforts, working with agencies and partners around the world, the goal being to reach every person who has TB, to cure those who need treatment, and to prevent the spread of new infections. Under our program, USAID's program called the Global Accelerator to End Tuberculosis, we support national TB programs with a focus here in Uzbekistan on developing new and cost-effective ways to combat multi-drug resistance tuberculosis. The Accelerator project builds local commitment and capacity to prevent, diagnose, and treat TB, and also to combat the stigma and discrimination against those who are infected with tuberculosis. Just over 2 years ago, March 25th, 2019, USAID and the Ministry of Health of Uzbekistan marked World TB Day by signing a memorandum of understanding on implementing the Accelerator to End TB. Uzbekistan was the second country in the world to sign such a partnership agreement. And the result has been strengthened cooperation between the US and Uzbekistan to build this country's capacity to stop the spread of TB. And again, especially the multi-drug and extensive drug resistant types of TB. We applaud and we recognize Uzbekistan's leadership and commitment to eliminate TB by 2050. And this is shown in its 2021 to 26 national TB strategy. The goal of that strategy is to reduce TB incidence rate by 50% and the number of TB deaths by 75% by 2025, just 4 years from now. The National TB Program aims to achieve the UN General Assembly high-level meetings TB diagnosis and treatment targets, focusing on drug-resistant TB patients, childhood TB, and treatment of latent TB infection. So again, by working together, and only by working together, we can continue to make the changes that will save lives and keep families healthy in Uzbekistan, across this region, and across the world. So again, a big thanks to our partners, to the Ministry of Health, to the center that Dr. Parpieva directs. Thank you for your partnership and your commitment to achieving our common goal, ending tuberculosis in Uzbekistan, throughout Central Asia, and throughout the world. Thank you. Kata Rahmat.
Thank you very much, господин посол.
Thank you, Mr. Ambassador. Now, I would like to emphasize
о том, что, да,
another matter, and Mr. Ambassador has correctly mentioned that Uzbekistan was the second country that has signed and participated in the TB Accelerator. This was initiated by USAID, but this is natural because tuberculosis service is under the personal control of the president. The president of Uzbekistan is personally interested that Uzbekistan will be one of the Central Asian countries that will achieve full eradication of this infection. But we understand that we cannot do it alone, and therefore the format of our conference is integrated control. So all our neighbors, all the countries should together fight tuberculosis. And in this, there is a great support provided by the WHO. The representative office is led by Lian Kupins. And now I'd like to give the floor to Lian. Moreover, all our joint activities with WHO are technically and financially supported by the USAID as well. So we are all together, and our integration is obvious, and we together fight TB. Please, Lian.
Assalamu alaikum, good morning. His Excellency, the Ambassador of the United States, Dr. Sabirov, Deputy Minister, Dr. Papiva, Dr. Dilom, colleagues from the neighboring countries, but also beyond, a warm welcome on behalf of the WHO to this indeed the 5th International Conference on the Integrated Tuberculosis in Central Asia. It's a great honor, a great pleasure, and yet I totally regret we are not physically all together because of the COVID. And the COVID will continue to be among us. We are afraid as WHO for the rest of our lives. We will not get rid of the virus. It will become kind of an influenza routine coming in waves and all that. And we have to find ways on how to indeed have the conferences effectively and productively, but we have to be creative in that regard. But coming back to tuberculosis, the topic of the conference, and although we know that globally, the WHO European region, including Central Asia, carries only 3% of the global burden of the TB, still the European region and Central Asia carry the highest proportion of the multi-drug resistant TB. This is not new. I'm keeping saying it every year. So we need to do more. We need to do things different to get out of this TB crisis we are in. We see a steady decline in the TB cases in Central Asia, and that's great. That's absolutely great. But as I said, the disease remains a serious major public health threat in the region. And the main challenges at the moment here in the region are, as was said already many times, the drug-resistant TB, but do not underestimate the TB-HIV co-infection. This is really another area of major concern. And we are very happy in the region, including Uzbekistan, that we have a relatively high case detection rate of 73%. This is great, colleagues, because we are able to detect well. But the treatment success rates of the multi-drug resistant TB patients is about roughly 60%. And this is not good enough. It is below the target of the tuberculosis action plan for WHO European region, which has a target of 75%. So here we are, we have 60% of success rate of the multi-drug TB patients. So not good enough. And that's also one of the reasons why we have ongoing transmissions. And then, colleagues, we had the COVID pandemic. Incredible. As I said before, that's why we have this hybrid conference. But the influence on the TB program was clear. It is there. And not only the TB program, the COVID crisis has had and is having an influence on all the essential health programs. It is quite amazing what happened and what is happening and what is continuing. So globally, we had estimated the impact of the COVID crisis on the TB. And we know we have an estimated number of patients enrolled in the multi-drug resistant treatment, which has been decreased with around 20%. So we are missing 20% of the people to be put on treatment because of the COVID. Imagine, this is the global figure, might be even higher in the European region, might be higher in Central Asia, might be higher in Uzbekistan. We don't know, we don't have the real data yet. And it is difficult to collect all this data. But colleagues, what I truly like to say, and I know it's on the agenda also in the coming days, but you have to think, what is this COVID crisis and future crisis, pandemics, epidemics in countries? What is it doing with a TB program? And how can we be better prepared? Because many of us in many countries, we observed that the essential programs got paralyzed. In some countries for quite a long time, in some countries for a relative short time. Uzbekistan, it was kind of stopped for a relatively short time, and I'm very proud of that. It was, the government really put pressure on to keep the essential programs alive. But then we also faced the problem that a lot of health workers themselves got infected with COVID. So again, it kind of paralyzed, health workers were repurposed towards COVID, but also in addition, health workers themselves got infected. And so in many countries, we got a paralysis of the system. But now knowing that viruses like this will continue to arise in the world, we have to think, what can we do as a TB program to be better prepared for continuation of these nasty, nasty viruses we have? Now, coming back to the TB and the situation, in 2019, we had around 20,000 TB people who died of TB in the region, which is equivalent to around 2.5 deaths per 100,000 people. Now, there were lots of variations within the European and Central Asian region, and it ranges from 1 death per 100,000 population to 9, the other extreme. And this particularly, the highest numbers, the highest deaths per 100,000 happens in the high burden countries. If you look globally, we have 194 countries and territories and all that. There are 30 countries which are perceived as TB high burden countries. 30, yeah? 18 of the 30 are in the European and Central Asian region. That's a lot, colleagues. So these 18 countries are, they are having more than 80% of the TB cases, and they are having 95% of the multi-drug TB cases of the region. So it's all centralized in these 18 high burden countries in the European region. And as I said before, HIV is becoming an additional challenge for us. The European region, if you look at the global picture of HIV, the world is doing pretty well. In fact, doing very well to reduce the HIV infection rates, except the European region. Except, and if we unpack the European region, what are we talking about? We are talking about Central Asia. The HIV is increasing in Central Asia. So, and this will have an impact on the TB epidemic also. So we have to, in the past, we sometimes talked about TB, HIV, dual epidemic and all that. Well, we have to be careful here that we are really serious tackling the two diseases, because it's not that we can just focus on TB. We have to equally focus on HIV. And we know that people with TB, HIV co-infection in the region are 7 times more likely to fail treatment and are 3 times more likely to die. And this compared to the HIV negative TB patients. So we have a job to do, unfortunately. In 2019, in the region, we have 12% of incident TB cases, which are estimated also HIV positive. So it's quite a lot, and it's scary. It's scary to know all of this. But as I said before, and as I raised, there are the 2 challenges. We have the multi-drug resistant and the TB HIV co-infection. But the multi-drug resistant TB, we cannot underestimate. It is a major, major concern. And according to the recent WHO estimates, the prevalence of multi-drug TB in the country, in Uzbekistan, and this is really great, has decreased and is now 12% in the new TB patients and 22% in previously treated patients in Uzbekistan. So a great success, yet we're still not there. Huh? We have to do better. But we also know that the long treatment duration is one of the factors why the adherence and all that is an issue of concern. And so because of that, the WHO encouraged in partnership with MSF, with others, to attempt reducing the length of the conventional multi-drug TB regimens. And lots of surveys and pilots are happening in Uzbekistan, and I'm very happy about that. So the use of a combination of drugs, which is tolerable and effective, but the duration time of the treatment very much reduced. And that helps, colleagues. That is tremendous. It's already happening a long time with very good results. And I'm very pleased also that Uzbekistan is one of the first countries with its piloted short regimens for treatment of multi-drug TB patients. And this under the leadership of Dr. Parpiva, Ministry of Health. We're doing great, yet we have to always do more. I'm always ambitious. We can do more. We have to do more. But just to say, colleagues, because I mean, TB, I mean, it's not easy for TB patients and that's why I think it's a continuing challenge in the world for many years, because there are lots of issues. And this is also what I like to highlight, the issue of trying to see the TB patients more as a whole, as a holistic person, rather than a TB case, a patient with a person with a TB disease. Because many of the issues are related to the additional cost, for example, additional cost of transportation, the food, the accommodation, all of this, when they are under treatment, is an issue of concern and sometimes a bit underestimated. We just say a TB patient has to come to the TB facility without thinking like, my God, can he pay it? Can he or she pay it? Is the person maybe depressed? Are there other reasons and factors which are contributing to the TB patient not coming back or not adhering to the treatment? But we know that with the short-term regimens, we are also addressing this because we are reducing also these costs and hopefully contributing to the positive behavior of the TB patient being able to adhere better to the treatment. And also, of course, if you have a TB case, you cannot work, you're hospitalized, and there are other costs involved. So also the productivity, the opportunity cost associated with the loss of productivity and the income. So, and another area of concern, which we know, is the stigma, the discrimination, and as I said before, the lack of adherence to the treatment. So we have to scale up the psychosocial support. We have to promote a more efficient use of the potential of the public, the government, the non-government organizations, the civil groups, etc., and their deeper involvement in the TB activities. And I'm very happy to see also that the Stop TB Partnership is also present here today because they are great for that. And many of the organizations present here today also. And we know, as I said before, we have to look a little bit beyond the TB as a person, as a patient, because it is related to poverty, depression, and as I said, cost, transportation, whatever, remoteness of the health facilities, all these factors we have to take into consideration. The government of Uzbekistan, together with their partners, we are making every effort to overcome all these challenges. We are doing everything. We're doing a lot, but we have to do more. And sometimes I think maybe we have to do things a bit different. Currently, WHO is supporting the implementation of the joint WHO-KFW and the joint WHO-USAID TB projects. And we are doing it successfully. And I'm very proud of what we are trying to do and the progress we are making. And we are obviously contributing to the overarching goal of the WHO to reduce the burden of TB and MDR-TB. And we provide the assistance to ensure universal and equitable access to the high quality TB services for the population. And the rollout, we believe that the rollout of new approaches in the TB case management through the different WHO projects we have is also transforming a little bit, as I said, the outdated TB vertical program. It's a bit vertical. We have to admit it is a bit vertical. It's not always nice to say, but we have to more into the other areas of this concern and make it a more integrated system which meets the modern equipment and is aligned with the international standards on the TB prevention and care. And I believe that the WHO recommendations recommending the new standards lay the foundation for better TB services that improve and save more lives in Uzbekistan and beyond in Central Asia, of course. We know that the annual TB, the international conferences are happening, and we are very proud of that. But we hope indeed that we are further discussing very fruitfully the coming 2 days, the enabling environment, financial sustainability for TB and drug-resistant TB programs to achieve the new goals. Also improving detection, the diagnosis of TB and drug TB, new opportunities to improve the effectiveness, and as I said, the very much important participation of the community affected by the TB, human rights, gender issues, all that we are addressing that. So it's a continuation of the job we are doing together. And I hope we continue for a long, long time to address what I would still say an alarming situation of TB, HIV, and multi-drug resistant in Central Asia. I'm wishing you a very fruitful 2 days, looking forward for good outcomes, constructive dialogue, and wishing you all a healthy life. Thank you.
Thank you very much, госпожа Lian Kupens.
Thank you very much, Madam Lian Kupens. Next floor goes to, I'd like to bring your attention to our screen. I'd like to pass the floor, and that will be Anna Berezovskaya, Portfolio Manager of Bank of Development and KfW Bank, and that will be a video welcoming remarks.
From the Ministry of Health, dear colleagues from WHO, fellow development partners, dear participants. It is my pleasure and honor to welcome all of you on behalf of KfW, the German Development Bank, to this year's International Conference on Integrated Tuberculosis Control in Central Asia. At the beginning, I would like to thank our very kind hosts from Uzbekistan, the Ministry of Health, the colleagues from WHO, and all of you who are supporting this event. The commitment of the government of Uzbekistan and the partner governments in Central Asia to the fight against tuberculosis is fundamental to curbing this public health threat to the region. TB remains the world's most deadly infectious disease. It claims more than 1 million lives each year. A disease that is preventable and treatable continues to have an enormously detrimental impact on people, societies, and economies. WHO reported in 2020 that TB incidence and deaths are falling, but not fast enough to reach global targets. But there is also hope. Since the first United Nations high-level meeting on tuberculosis, the number of people treated for TB has grown, with over 14 million people reached with TB care in 2018 and 2019. The number of people provided with TB preventive treatment has quadrupled from 1 million in 2015 to over 4 million in 2019. At this point, I would like to congratulate the Central Asian governments who put great effort into improving the existing national TB control programs. Moreover, I would like to remind you of the German government's commitment to fight against tuberculosis, which places a special focus on the Central Asian region. Through KfW, a total of 50 million euros have been made available for the fight against TB in Central Asia. In the framework of financial cooperation, KfW has supported the national TB control program in Uzbekistan for many years, currently focusing mainly on the modernization of reference laboratories and systems of quality assurance. We are also active in the area of training and capacity building in cooperation with WHO in order to strengthen integrated, patient-centered care and prevention. Yet, there are major challenges ahead. Not only has the COVID-19 pandemic shaken the world in ways previously unimaginable, it also has threatened the gains made over recent years in the fight against tuberculosis. The impact of the pandemic on TB services has been severe. Data collated by WHO from TB high-burden countries shows sharp drops in TB notifications in 2020. This calls for existing commitments to be upheld to prevent additional suffering and death. TB does not know borders. If we want to find answers to the often very complex problems of TB control affecting the Central Asian countries, we will need all the knowledge and experience available in the region. Within the framework of German development cooperation, KfW supports the exchange of knowledge and experience in the Central Asian countries. I'm confident that over the next few days, both thematic discussions and personal exchange will be productive and lead to increased advocacy for political leadership and commitment to TB control. Once again, I would like to thank everyone who helped make previous conferences a success, and all of you who have worked very hard to organize this year's conference. May we continue to work together successfully towards fighting TB in this region and improving health in the Central Asian region. On behalf of KfW, I wish this conference success and encouraging results. Thank you.
Огромное спасибо Анне Березовской. Ну, вот видите, пандемия ковид вносит свою коррекцию, вносит, конечно, очень много изменений в нашу жизнь, но с другой
COVID introduces changes and, of course, contributed, of course, to the whole healthcare situation. But there is another area that has been developed with COVID. It is the online communication. So our next welcoming remarks was by the Stop TB Partnership representative, but we lost the connection. So if you allow us, let us not stop on that, but we will just come back to that matter later on. But right now on the screen, you will see the video spot with regard to stigma and discrimination. And I kindly ask our visiting guests to go to a special room for mass media communication. And in 15 minutes, we will get back to the conference.
Kasalligi bilan kasallangan. Silga chalingan odamlar davolanish paytida nimani his qilishadi va nimaga duch kelishadi?
Eng qiyini o'sha muhitga kirish, birinchisini shunaqa deb o'ylayman, o'sha muhitga moslashish qiyin bo'ldi. O'sha kasallik ekanligini tushunib yetish va uni hazm qilish qiyin bo'ldi.
Davolanishga harakat qilib, dori-dormonlari ichib, qancha qiyinchiliklar bilan ukollarini olamiz-u, dorilar ichganimizda ko'proq stress holatida bo'lardik.
Davolanish kursiga to'g'ri rioya qilishda doktorlarimiz har kunlik menga qilayotgan mehribonchiligi, ruh bergan davolanishni bardavom qilishgan.
Yo'q, ichmaymiz desak, vrachimiz kelib tushuntirib ketardi. Bu sen organizmingga kerakli narsa, mana shu narsa bo'lmasa, sen aholing bu narsani vaqtida amal qilib ichsang, sen o'shancha tez yaxshi bo'lib ketasan. Boshqalardan qayering kam deb vrachimiz ko'proq tushuncha berardi.
Hamma birgalikda harakat qiladigan vaqt keldi. Oilangizni sil kasalligidan saqlang. Hozir davolanayotganlarni qo'llab-quvvatlang.
В 2019 году в мире туберкулезом заболели 10 миллионов человек. Заболеть туберкулезом может каждый. Что чувствуют и с чем сталкиваются лица, затронутые туберкулезом при прохождении курса лечения?
Во время лечения сложнее всего, что вот эта побочка. Во-первых, много препаратов, Я не знаю, но для меня это тяжело было, во-первых, что организм ослаблен, я...
Ну, сложный период, конечно, когда я находилась в больнице, достаточно длительный срок все-таки, далеко от семьи, от детей, за что переживала. За детей особенно.
Ну, это прежде всего желание жить во время лечения меня мотивировало. Ну, назад повернуться жизни не было. Ну, честно, вот так если сказать. А вперед, конечно, хотелось что-то нового.
Общение с людьми, доктора поддерживали. Доктора говорили, ничего страшного, это все излечимо. Ну, общая мотивация была. Друг друга поддерживали в больнице, когда находились.
Настало время действовать всем вместе. Защити свою семью от туберкулеза. Поддержи тех, кто находится на лечении сейчас.
мувофиқи омор дар соли 2019 тақрибан 10 миллион нафар дар саросари ҷаҳон ба бемории сил гирифтор шуданд. ҳар нафар метавонад гирифтори бемории сил гардад. ҳангоми табобат нафарони гирифтори бемории силро чӣ гуна ҳиссиёт фаро мегирад ва онҳо бо чӣ мушкиле дучор мешаванд? ман гирифтори бемории сили шакли мутобиқ гашта мебошам. барои табобати ин беморӣ дороҳои зиёде мавҷуданд. дар давоми табобат марҳилаи мутобиқшавӣ аз ҳама мушкил буд. бале, табъиз дар муносибати беэҳтиромӣ аз ҷониби баъзе шахсон эҳсос карда мешуд.
хӯрдани доруҳо буд, мушкилиҳои зиндагӣ буд.
дар атрофи ман ҳамеша наздиконам буданд, аммо мутаассифона нафароне низ ҳастанд, ки аз ғамхории наздиконашон маҳруманд. ин муҳитро ҷомеа, табибон, волонтёрон, ҳамсояҳо фароҳам оварда метавонанд. ман дар лоиҳаи USAID оид ба барҳам додани бемории сил дар Осиёи марказӣ ба ҳайси корманди саҳроӣ дар шаҳри Нора кор мекунам.
уже барои кӯдакам зиқ шидам, гуфтам бо касал нашаванд, майда ки буд. баъд рафтам табобат кардам ба хотири ҳарҷи фарзандам, ба хотири саломатии худам ки дар болои сари фарзандон бошад. ҳозир ман муддати қариб 3 моҳ мешавад дар лоиҳаи USAID оид ба баҳрам додани бемории сил корманди саҳроӣ кор мекунам. доим бемории сил.
вақти он расидааст ки ҳама якҷо амал кунем. биёед оилаи худро аз бемории сил ҳифз намоем. ба онҳое ки ҳоли ҳозир аз ин беморӣ табобат мегиранд дасти ёрӣ дароз кунем.
Уважаемые коллеги, мы можем продолжать работу. Я слышала, что уже Севим Ахмедов на связи.
Dear
Севим.
colleagues, I think we can continue. Sevim, good morning.
Good morning, salam alaikum.
Пока
Good
он
morning.
подключается, я хочу объявить о том, что у нас первая
I
пленарная
want to announce that the first plenary session, which is called Global Strategies on we'll have the moderators, Sevim. Good morning, Sevim, again. Good to see you. I think we'll give floor to Sevim Ahmed so he could give us a welcome speech, and then we can moderate our. Go ahead, sir.
Parpieva, salam alaikum. My name is Sevim Ahmedov, and I'm the TB HIV prevention and monitoring and evaluation team lead with USAID in Washington. So let me, it's a great honor and pleasure to moderate this first plenary session. And I would like to welcome everyone to this first plenary session, which is planned to set the context for the rest of this conference. But before we start, let me express my sincere gratitude and appreciation to the organizers of this event, and especially acknowledge the national leadership and the commitment of the government of Uzbekistan, as well as Dr. Parpieva, to the fight against TB. It is my pleasure and honor to introduce our first distinguished speakers for the plenary. Although Professor Dr. Parpieva does not need special introduction, she has had a distinguished medical research and program management career, from graduating with honors from the Medical Institute in Tashkent to holding several prominent positions currently as the head of the Department of Phthisiology with the Tashkent Medical Academy, with a combined position as the head of the Department of Diagnostics and Therapy for TB and HIV of the Republican Specialized Scientific and Practical Center for Phthisiology and Pulmonology. She also serves as the director of the Republican Specialized Scientific Practical Medical Center of Physiology and Pulmonology. But what really distinguishes Dr. Parpieva is her global leadership in the fight against TB. She has set a very ambitious goals for the TB program, as she will walk us over in the next couple minutes, and it is a really honor and pleasure and really privilege to have Dr. Parpieva as a distinguished colleague, and also, if I may, Dr. Parpieva, to say as a friend. So with that, I would like to turn it over for the first presentation to Professor Dr. Parpieva, and remind everyone, if there are any questions, please add them in the Q&A section of the of Zoom, or put them in the chat. Thank you very much, and Dr. Parpieva, the floor is yours.
Thank you very much, Sevim. Спасибо, Sevim, вы так тепло нас представляете.
Thank you, Sevim, for a warm welcome. Yes, indeed, we've known each other for many years. Yes, we are really true friends, and it's really pleasing. I'm really happy to moderate the first plenary session of today's conference. And if somebody does not understand, so we'll have 6 presentations during the first plenary session. And if somebody has questions from among participants, you can send them via chat. Since the first floor is given to me, allow me to introduce you to my presentation. Please bring up my presentation. I would like to talk about the implementation of the national program to end to TB in the Republic of Uzbekistan, achievements and further steps, further goals. Since we are restricted with time, shouldn't be more than 15 minutes each presentation. That's why allow me to talk about important parts. So when I talk about the country, I wanted to change. On the 7th of September, of this year, 2021, the population of the Republic of Uzbekistan has exceeded 35 million people. The territory is the same. So moving on. In our country, starting from 1994, we started the gradual strategy. So the first strategy which we started implementing in our country, this was a strategy, this was a WHO strategy. And after that, by the way, thanks to the FMS, we were the first pilot project in the Republic of Karakalpakstan. After that, we then covered the entire country. And later, after achieving positive results under this strategy, we then switched to following other new strategies. I think I'm in the wrong slide right now. I will try to get to the right slide. So here we are. So what other reforms were there? In 2009, there was a Beijing Declaration. In 2011, starting from 2011, when the World Health Organization announced about the start of a extensive fight against the MDR. We then developed a roadmap back in 2011. So the activity started according to this roadmap from 2011 to 2015, and in 2012, with technical assistance from the WHO, we developed a national prevention plan against the MDR TB in the Republic of Uzbekistan. And if you look at this very slide, then you will witness that all around the world, including the Republic of Uzbekistan, back in the year 2000, 2001, and 2012 was the peak of TB incidence and mortality rate from TB. But thanks to the law which was adopted back in 2001, law on protection against TB, and then other normative acts and documents, legislative documents, and introduction of all the latest recommendations by the WHO in the Republic of Uzbekistan, we stabilized the situation, and we were able to reduce this number. And you can see the numbers that over the past years, the incidence rate decreased by twofold, and mortality almost by 6 times. And today, there was a figure not 2.1 but 1.2. So the mortality rate in the Republic of Uzbekistan, apologies for that, I am correcting the numbers. So it's of course, over the past couple of years, and then COVID impacted, and I must say here that last year, the Republic of Uzbekistan, just like any other country, when Uzbekistan faced this new challenge, this new infection, and first of all, it's our TB service in Uzbekistan, our regional divisions, units of Phthisiology and Pulmonology divisions, they were responding to COVID, and because there were COVID centers were set up in these institutions, and of course the parameters was reduced in diagnosing TB, and currently we are increasing the capacities of our TB service in the primary section, in the PHC level in the country for diagnostics. I will tell about this later on. So the cornerstone in the fight against TB in Uzbekistan, I would even say revolutionary. There was our current president and prime minister then prime minister, Mr. Shavkat Mirziyoyev, he issued resolution number 62 on the 5th of March 2011. So this decree by the cabinet of ministers about additional measures to reduce TB incidence rate in Uzbekistan for 2011, 12-15. This is a state program, governmental program, which we implemented successfully, headed by our TB service. There was Mr. Mirzagolov Dugmatovich. By creating a new TB team, together with our international partners, we implemented this various state program and we achieved the following results. Number one, the first postulate was the motivation involving personnel into Uzbekistan, because when we were starting together with Professor Telashakov, there was only 50% personnel, number of personnel, and the first motivation was to increase the salary for this personnel. Number two, so the fundamental change in creating the material and technical resource base for our work. So we're talking about reconstruction in almost 40 TB institutions all around the country for the total amount more than 176 billion sums. So equipping all these centers, TB centers. So over the past 5 years, we were able to raise the issue of graduality or provision with the personnel from 50 to 83%. Again, this is the personnel. We trained a huge army of personnel. By the way, while training these new specialists, the focus was given to new recommendations by the WHO, World Health Organization, and one of such huge steps of ours, which this is by the way something we started with. We canceled all the then normative acts existing back then. Based on the new recommendation by the WHO, there was a one normative document was adopted. It's a table book for any physiologist, which reflected all our normative acts, documents, using which our TB service started its operation. Moving on, here you can see some pictures of the construction. First of all, our head institution, head office, which was being reconstructed under our then Prime Minister, now currently President of Uzbekistan, and we created all the conditions were created for us to successfully fight and work in this new area. So, and of course, so huge, biggest document, the most authoritative document is the decree by the presidential resolution on 13 February 2019, number 4191, about measures to improve the system of specialized physiological and pulmonological assistance or support. So this very document, so the main tasks are reflected in these documents are the following. First of all, this is the restructuring of our service, TB service. In other words, in each and every vilayet region, based on the regional TB dispensary clinics, we created branches of our center, but they are independent legally. These are the regional physiology and pulmonology centers. And the reason is to create comfortable conditions for our population. Instead of coming to just one institution and somebody patient who have experiencing respiratory pains or cases, they can come to our regional centers, and while being diagnosed for TB, so they get treatment in these TB centers, and after diagnosis has done, and if the diagnosis is complicated, then they have diagnostics departments. So for the equipment, large amounts were allocated for the equipping, and it's still continuing. The reconstruction work is underway. Also, the personnel policy, HR policy is also continuing. We're developing the production of, for example, our proposals. According to our proposals, so the country is manufacturing of UV lamps, and we also have various types of means of PPE and so on and so forth. But again, one of the most important points that I would like to draw your attention is that under this state program, there are changes of the vector of prevention, of prophylaxis of TB, for diagnostics of latent forms and development of new regimes for chemoprophylactics, prevention of these latent forms of TB. In addition to that, a new principle of financing. This is we're talking about introduction of improved model of financing, and today's conference will give us opportunity to get to know, to learn about the methods to switching to medical insurance, which in Kyrgyzstan they already have that, and we are at the very beginning of transition to this medical insurance. But we also have treatment, palliative TB treatment in Uzbekistan. What we have done so far, several orders. Order number 89 on latent groups on special paths. They are selected and the work is done. This is order number 90 of the Minister of Health. For the first time, this order is about the medical assistance as far as pulmonological assistance, and the fundamental order number 173 back in July, 1st of July 2019 by the Minister of Health. And according to this order, there's been a restructuring done not only of the TB service vertically in the entire country, but also the
the man table was also changed. In addition to that, in this very decree, presidential decree, provides for now Uzbekistan is switching to partial procurement of TB drugs, which I will talk about later, and this was in the cabinet minister resolution about simplified procurement. I must say that all this drugs bought from the state budget, everything is done through the GTF. This is with qualified drug qualified by the WHO. So protocols, personnel training. On these pictures, you can see how together with the World Health Organization and our international partners, we've conducted training of more than 600 specialists in our area. So we didn't waste time during COVID. And we had online and offline trainings, as you all are aware, to be able to train new protocols which are adopted in the Republic, which have been adopted in Uzbekistan. But nevertheless, I would like to separately talk about Decree number 62. There was a unique 5-level network of laboratories around the country. So over these last years, it's been improved. So we are improving, and of course, we enhancing the level of diagnosis at the PHC level. And I can proudly announce that this was our dream to introduce a gene expert, which allows us to, instead of 3 months, now we can do it in 72 hours. We are able to diagnose the presence of microbacteria of TB and the MDR forms of TB in order to be able to start treating from day one and use the right regimen of treatment and complying with the TB infection requirements. And by doing that, I am certain I can assure you that each TB service in the country, we prevent intra-hospital transmission of TB by observing strict infection control requirements. By the way, the equipment is helping us during the first and second stage of our laboratory services, the newest gene molecular methods of identifying microbacteria. This is old information, by the way, on this slide, because there used to be 65 gene experts, and thanks to the USAID now, and plus our international partner Global Fund, now this number has increased, and we're getting this new equipment. So we're talking about more than 40 gene experts, and yesterday we were discussing this with my advisor Sharaf Yildash, that it's a 6-color gene. We're already getting gene experts that allow us to identify not only AMLO but also XDMR of TB. We have enough number of bactecs in all the regions of Uzbekistan, and of course the HAIN equipment HAIN. And I want to proudly announce that we are always together with our supranational laboratories in Gauting. I would like to thank them separately. We are always in online mode. We work with them together, and the proof to that is all these certificates of quality certificates that our laboratories are getting. Now, shortly about our achievements. As you know, the plan, WHO plan to reach 85% of success rates in all forms of TB. First of all, Uzbekistan reached 91%, by the way. So we are at a very good rate. We're trying to achieve the top point, which is 75%. Now we have 68% in Uzbekistan. So the success rate of short term, again, I would like to repeat here that Uzbekistan is in the region is #1 country in the region, which together with we started developing 9-month courses, and after that we now have multispectral research on introducing short-term regimen and new treatment regimens, and achieved beautiful results. And vaccination we started back in 2011. We stopped doing this revaccination. We only do the vaccination covering 99.6% of all newly born infants, and we did not observe a growth of incidence rates, TB incidence rates among children, and in the age group, the ones that we used to revaccinate in the past, now we're stopped doing that. So this is a programmatic approach, which in fight against TB among all the population layers, and there's no need to go back to revaccination. We don't see any need in that. We are continuing to do chemia prophylaxis among children So the contacts which we have, and the number that I wanted to give you, of course, it's approximate over the past 2014 through 2020, Uzbekistan saved more than 114,000 lives.
Unfortunately, in several countries in our region, there are some sporadic cases of death, and our key objective is to ensure that no family in the future is affected by this disease. And I also wanted to mention immune diagnosis before 2015 to 2016. Since 2009, we had no opportunity to procure tuberculin, and in 2000, production of tuberculin stopped in our country, and definitely much attention was paid to that. And now our country procures tuberculin and their skin tests. So it's state procured, and I have good news. So from the state budget, lately we reached a decision with the Ministry of Health, with our leadership from the presidential administration, to channel the savings from the state budget to procure tuberculin for our race groups. And I have to say that Uzbekistan participated in testing of quantiferon, and actually it went quite successful. And later on, the plan is to procure, well, I guess, first of all, thanks to our partners, quantiferon will be procured for our country. And as for anti-TB drugs, the plan is to ensure a stepwise transition, and we procured from the state budget first-line drugs and partially second-line drugs, and as for most of the first-line drugs and third-line drugs, so the Global Fund helps us do this. As for international cooperation, it is ongoing. In 2016, as I said before, we opened the first site under to be practical. So it is multi-central international studies to introduce new anti-TB drugs. And in 2018, this site was opened under our center. It is titled the Department for Innovative TB Treatment. And it is my pleasure to mention that among all TB services nationwide, it was our TB service. And thanks to USAID support, here you can see the opening on the 12th of April 2018. So at our service, the Innovative Distance Learning Center was opened, which enabled us to introduce telemedicine. And we opened the hub in our center, and in 7 provinces, similar sites were opened, which made it possible to do telemedicine. And it was especially a high demand during the COVID times. And jointly with USAID and APT team, we are expanding our opportunities. And it was also mentioned today on the 25th of March 2019, when we were celebrating the World TB Day. The memorandum was signed for further cooperation between USAID and the Ministry of Health. On 11th of February 2020, the BCA bilateral collaborative agreement was signed between WHO Regional Office for Europe and the Republic of Uzbekistan. We were especially pleased that the first visit of Hans Kluger as a regional director was paid to Uzbekistan. He was encouraged by the efforts made by the National TB Program jointly with the international partners in the area of TB control. And we conduct multiple briefings. We engage the communities, the population, and over 3 years, over 90 mass media messages were disseminated. So on top of the slide, you can see International Press Club and in the online mode, representatives of USAID, APT Associates, MTP, Ministry of Health, participated in the briefings. They answered questions asked by our journalists. We repeatedly delivered messages over television, and not only on TB, because we were also engaged in anti-COVID efforts, and definitely a lot was done. So more than 140 articles were published in the leading journals, and jointly with MSF, we publish our articles under Sort IT and the leading global journals, highlighting our achievements. And we always share our achievements. And finally, I would like to highlight the key indicators under MTB strategy. Before 2025, we officially declared the reduction in mortality by 75%, and also the as for mortality rates, the 15% was achieved, and as for incidence rate, yes, actually it is in progress. And what I have to say is that even if the person contracts TB in our country, the treatment is provided and is mostly successful. And as for resolution number 4191, the great role is also played by integrated TB control, which is the spotlight of our today's conference, and also the TB in migrants among our countries and other countries. And this problem also receives special attention. I would like to thank you for attention. And if you have questions, once again, a reminder, you can write your questions in the chat. Sivim. Thank you very much, Dr. Parpiv.
Presentation. Thank you very much for walking us through and giving the historical perspective of what a sound foundation the TB program has in Uzbekistan under your leadership. And we always say the political commitment is one of the most crucial ingredients that we need to have in the fight against TB. And it's really great to see such an expression of such a strong political commitment that comes from the side of the government of Uzbekistan and under your leadership for this program to have achieved these results. Given that we are a little bit running short on time, if there are any questions, we will have hopefully some time for Q&A, questions and answer session at the end of the session. But for now, allow me to introduce the next speaker, Dr. Askar Adalbayev, and Askar also doesn't really need an introduction, and I'm sure he's known to everyone who has joined us today at the conference. But Askar is leading the TB program at WHO, the regional office of WHO. In Copenhagen, and he's also a very, very dear and distinguished colleague and friend. Thank you very much, Askar, and the floor is yours for the next presentation. Thank you.
Большое спасибо, уважаемый.
Thank you so very much, dear Sivim, for this opportunity to take the next floor. And I would like to first of all extend my deepest gratitude to the Ministry of Health of the Republic of Uzbekistan, to the National TB Program of the Republic of Uzbekistan, to USAID, KfW, to all partners and organizers of this 5th International Conference on TB Control in Central Asia. It is my honor to speak at this high-level meeting, and I would like to send my best regards from all colleagues from WHO Regional Office for Europe and personally from Dr. Hans Kluge. It is my pleasure to see that at this very conference, all 3 levels of WHO are participating: the country office, regional office, and the HQ of WHO in Geneva. And I would like to share the first slide. Please tell me if you can see my slide on the screen. It is quite challenging for me to speak after the first speakers, especially after those who highlighted quite a few key anti-TB issues in their presentations. And it was also very nice to hear from distinguished Ms. Partieva on the progress and TB control in Uzbekistan. But in my presentation, I would like to discuss the situation in the region, like what is the current stage and implementation of the TB strategy in our European region. I would like to share the progress and the plans after 2020. So as you are all well aware, in WHO Regional Office for Europe, for the period 2016 to 2020, there was the plan against TB, which set specific goals and objectives to decrease incidence and mortality. And I would like to mention that currently this regional plan is finished, and on the WHO Regional Office for Europe's website, the final report is published, which highlights all the achievements reached jointly by 2020. And namely, I would like to mention that as for incidence and mortality, the WHO region almost achieved the targets reached for 2020 under the TB strategy. And as for the incidence reduction rate, so it was like 90%, although the target was 25%. As for mortality declines, well, over the 5 years, the actual rate was 31%, and the set goal was 35%. But it all happened before COVID-19 pandemic. You are all well aware that in September, in New York, at the UN meeting, all countries undertook commitments to fight TB, and they will need to be achieved by 2023. And now we do have data on achievements over the first 2 years, 2018 to 2019, and I'm happy to present to you those achievements. So the first part is about TB preventive treatment. And the objective was to include in preventive treatment globally at least 30 million people. The share of WHO region in Europe accounts for 2 million in 2018 to 2022. So at the first stage of implementation, we can safely say that, in fact, in our European region, the coverage with preventive treatment for all age groups is not sufficient. Only 9.5% of the reached target of 2 million received preventive treatment. There are multiple reasons for that. Low priority for preventive treatment in many countries in our region, inadequate financing, unwilling health professionals, and also the access to diagnostics of TB infection, and also access to drugs which are used for TB preventive treatment. This is also relevant for contacts in families under 5, and namely those age 5, and also people living with HIV/AIDS. And that's why quite recently WHO issued its call for all countries in July 2021, calling for countries to enhance TB prevention measures So targets could be reached by 2023, and all countries will report in 2023 on the progress towards those goals. And unfortunately, TB, as stated before by many speakers, still remains a serious problem in public health in many regions globally. And quite recently, WHO revised the list of countries with high burden of TB, TB HIV, and MDR TB. And I would like to mention that there were a lot of changes which are relevant to countries and the European region. So as for high burden countries, currently Russian Federation is excluded from that list, but anyway, Russian Federation is on the list of countries with high burden of TB HIV. And it suggests that the problem of TB HIV, so as just mentioned by Dr. Lian Kupins, head of country office, is a very serious problem. And the trend is upward in our region as for this very problem. And as for drug-resistant TB, now WHO is identifying the list of 13 countries with high burden of MDR TB. These 13 countries account for some 90% of the overall global MDR TB burden. And I would like to highlight a very important detail that 9 of 13 countries are countries and European region of WHO, including Azerbaijan, Belarus, Kyrgyzstan, Tajikistan, Ukraine, Uzbekistan, Federation, and unfortunately, as for a drug-resistant TB in our region, as I said before, it's a very serious problem. As for the share of primary drug resistance, as of 2019, it accounts for 17%. As for previously treated patients who previously received treatment against TB with TB drugs, it accounts for 52%. So it's a very serious indicator. And so most of them are patients previously treated in need of adequate, relevant treatment in line with the most recent WHO recommendations. Unfortunately, in our European region, we report annually 70,000 cases of MDR TB, and mostly these patients are concentrated in Eastern Europe and in Central Asia. Unfortunately, in Central Asia countries, in 5 countries, Kyrgyzstan, Kazakhstan, Tajikistan, Turkmenistan, and Uzbekistan, up to 20% of patients with MDR-TB are notified. The same is relevant for estimates. Estimates of patients with MDR-TB. And so this necessitates a high level of commitment by partners, by WHO, by countries, so we could join our efforts against this severe disease. And I would like to highlight that the goal which was coordinated and relevant commitment were undertaken at the UN high-level meeting in September 2018. So 40 million people with TB globally must receive treatment. WHO European region ensures universal coverage with treatment and access to this treatment. In principle, over 2018-2019 in European region, 36% of patients were enrolled in treatment programs. And we do hope that the objective 1.23 million to be included in the treatment programs could be reached. But we have to enhance our measures for MDR and TB diagnosis. We need to enhance access to new TB drugs in line with WHO recommendations, and we have to enroll patients in treatment programs so we could reach high results. This slide shows the results of treatment for TB patients, and if we discuss the effectiveness of the STB treatment, drug susceptible TB treatment, overall our region accounts for quite good results. But I would like to draw your attention to the fact that the TB HIV co-infection demonstrates quite low results in treatment, 51%.
This is according data of 2019. The success of treatment of patients with multi-resistant form and patients which are resistant to fluoroquinolone, which is suboptimal. And according to cohort of 2017, which you can see on this slide, published in 2020, the success in treatment was 59% among the patients of TB patients and less than 50% with the wide drug resistance. This is not the optimal. And these results most probably are related to the fact that during a cohort of 2017, the expansion access to new TB drugs was not big. And therefore, in the next cohort, we are expecting better and high results in treatment of both forms of tuberculosis. Unfortunately, during more than 1.5 years, the entire world is living in COVID-19 pandemic, and WHO, just like many other institutions, has made the estimation and modeling of that the reduction and detection of TB during a certain period of time can drastically increase TB death cases. And this is also related to our region, that the delay in the reduction of the level of registered TB cases can lead to drastic increase of death cases among TB patients. Last year, World Health Organization in our region conducted an overview of monthly registration of TB cases from January to June 2020 in comparison with similar period in 2019. And you can see to what extent pandemic has affected. So reduction of the identified cases in European region in many countries that provided data was equal to 48%. Mostly we link it with restriction measures that many countries have introduced as a response to COVID-19 pandemic. Many patients have stayed at home. Many health services, including TB services, as Nargiz Nusratovna said, were in front line on treating patients with COVID-19, and that mostly, and there are many other reasons, of course, which affected the reduction of the detection. This is observed in many countries of our region. So here you can see 6 countries of Eastern Europe and Central and Western Europe, where we can observe similar trend. This is analysis data for January and June 2020 in comparison with 2019. But nevertheless, the trend is continuing now during entire 2020 and 2021. There is a slight improvement that we can observe now, but still pandemic is affecting negatively to the detection of the TB cases. If you pay attention to this slide, so before pandemic, monthly for treatment of multi-resistant form, we have seen 4,000 patients every month. And during 9 months of COVID-19 in 2020, you can see reduction to 25%. So about 1,000 TB patients, since they have not been detected, have not received the treatment. That can lead to negative consequences and increased level of death, which can eliminate all our results that we have achieved till 2020. As of today, we have a big opportunities to improve preventive treatment and increase the
Всемирная организация здравоохранения за период
treatment of both forms of TB. WHO has published a series of modules of consolidated WHO guidelines, which are focused on prophylactic, systematic screening, diagnostics, and treatment of the drug-resistant TB. By the end of this year, we are expecting new updated guidelines on treating child tuberculosis and drug-resistant tuberculosis. All these recommendations, which are being published by the WHO, they're based on the experience of countries, strong evidence-based, and recommended by the WHO for application. And therefore, the assistance of the WHO will be focused on the preventive treatment, systematic screening of tuberculosis in order to improve the coverage by using systematic screening or active detection, by using computer diagnostics of pathologies related to TB and computer-aided detection of tuberculosis. Also, a big attention is paid by EU WHO office on expansion of countries' access to the rapid molecular methods of treatment of tuberculosis. These methods also allow to diagnose tuberculosis, HIV, virus, hepatitis, and COVID-19. And a big attention also will be paid to the quality treatment to drug resistance, so we can make a good diagnosis and start the treatment. Big attention in our region is paid and will be provided in treatment of TB and treatment of the drug-resistant TB. The main message today in the trajectory of the WHO is to transit to fully non-injection, fully perioral treatment of both forms of tuberculosis. And we, as EU office, European office of the WHO, provide support through the regional initiatives, which is the committee of the green light, regional initiative of the modified short mode of treatment, BPAL mode, and new research which is planned now, and the viruses hepatitis C, as well as we will also spend some efforts on nutrition and other treatments. We also expand the access to the digital technologies. We provide assistance and expand the video surveillance during treatment for both resistant and sensitive tuberculosis. This is patient-oriented approach, which is efficiently helping reduction of the COVID-19 and stigma and discrimination during treatment of patients. One of the opportunities to make the virtual consilium or expert assessment. So many countries of Central Asia and Eastern Europe actively participate in this, and we are happy to provide assistance in this. Briefly, I would like to tell about this, and we have a separate presentation on this, which is transition to fully non-injection treatment methods. In USAID, also supported operational guidelines to treat tuberculosis, which is implemented in 14 countries of high priority in European region. These are the patient-oriented work, our initiative, and it allows to reduce the RPM for tuberculosis and reduce 6 times the number of the drugs which has been recommended by the WHO. And this regional initiative is currently implemented in 14 countries where we have 1,400 patients. And many of them are in the Central Asian countries. And video surveillance is something that I talked about already. We call it video surveillance, but not video escort, because we also provide assistance, social, psychological assistance that helps the patients to complete the therapy. And we would like to ask all countries to consider this opportunity as most optimum, and happy to provide technical assistance in this. Social psychological support. Focus on socially vulnerable people. This is one of the priorities of our work. And we would be happy to continue working in this area and cooperate with you and countries in order to study and expand this multidisciplinary approach. Let me also mention that WHO European Office is developing the roadmap of the European region till 2030, which in integration of all the events focus on prevention, increasing the screening and diagnostics, and the coverage of non-injection forms will allow us to achieve the NTB goals by 2030 and eradicate TB in 2035 in our region. And only together and jointly we'll be able to achieve these goals. This document, this roadmap of the WHO European region will be developed by the end of 2021 and provided to the countries for their attention by 2022, and would be happy to receive your contribution to this document. In conclusion, I would like to thank all colleagues in the country offices in Central Asian countries, all member states and partners and local communities, and civil society institutions for their assistance in preparation of this presentation, and thank you very much for your invitation.
Thank you very much, Askar, and thank you very much also to WHO and to your leadership. Without the work and the policy guidance that WHO works so hard on, we will not be able to do our jobs. Thank you very much for this excellent presentation.
Я тоже присоединяюсь. Оскар, спасибо вам большое.
I also would like to thank Askar. I'm very sorry that I had to step out to participate in the press conference. Thank you, Askar. And I would like to invite our next speaker, and especially I would like to introduce you to my colleague, moderator, Sevim Akhmedova, who is for more than 25 years has been working in the public health. He has a big experience of working in UNAIDS. Before that, he worked in NTP Bulgaria. So he has a big experience of work in USAID. And for Central Asian region, Sevim is supporting us in developing plans of work, promotion of our programs. And once again, I would like to say that in Uzbekistan, Sevim is not only our colleague, but a big friend. And I would like to give the floor to him, and the presentation is called Global Accelerator on tuberculosis. Thank you very much, Dr. Parpiva.
I'm blushing. Thank you very much for your kind words. I hope you can see my slides, and let me apologize in advance that I'll speak in English, and thank in advance our wonderful interpreters for the Russian translation. I would like to provide a brief overview of the Global Accelerator for TB. Just look at the historical perspective in terms of the implementation of the USAID global strategy for tuberculosis over the last 5 years. As you can see on the slide, with USAID support, the 23 countries that are receiving direct bilateral support from USAID, we have been able to achieve some significant reductions, both in the TB incidence in the last 10 years, as well as reduction in TB deaths in our USAID supported countries. This is, of course, an example also, though, of the enlightened leadership and the commitment of these countries to work with USAID and with our partners to be able to achieve these significant results. And globally, it is a great achievement that it is estimated that over 60 million lives have been saved in the last decade. Similarly to the reduction in the TB incidence and TB case fatality rates, as you can see, also significant success was achieved in terms of the treatment success rate for drug susceptible TB, and the total number of successfully treated individuals with TB has been over 16 million for the last 5 years for the implementation of the USG strategy on tuberculosis. And although we still face significant challenges when it comes to drug-resistant TB, there also has been progress in terms of initiation of significant number of individuals with drug-resistant TB on anti-drug-resistant TB treatment. So while we acknowledge the significant accomplishments, in 2018, September 2018, as we all know, the UN high-level meeting on tuberculosis took place in New York City, and there were strong commitments from the global community and significant number of countries which committed to the UN high-level meeting targets, which were set at that meeting. USAID also committed to support to provide full support for the to the countries to reach those ambitious targets. And during that UN high-level meeting, the Global TB Accelerator was launched. And since then, USAID, working with partners, working with our national government counterparts, we have been operationalizing the implementation of the Global Accelerator to end TB. And in terms of the programmatic framework and the main elements of that accelerator, were the development of these partnership statements or memorandum of understanding between USAID and the national governments. And it was already mentioned by our honorable ambassador. Uzbekistan was one of the first countries where USAID is working in that had signed this memorandum of understanding. And I would like to congratulate again the Ministry of Health and the government of Uzbekistan for their strong commitment and in getting this partnership statement or the memorandum of understanding signed and approved. In addition to the partnership statement, currently we have over 20 partnership statements.
Помимо этого, мы также заключили похожие партнерские заключения, меморандумы, простите, и они также сейчас реализуются в рамках дорожных карт в странах по борьбе с туберкулезом. И это очень действительно помогает лучше реализовать те принципы, в которых мы пребываем, когда отрабатываем партнерские соглашения. Кроме того, это также реализуется через механизмы работы наших партнеров. Есть определенные достижения. Помимо меморандумов о взаимопонимании, мы разработали более 37 местных специальных соглашений сетевого характера, network agreements, и либо с Министерством здравоохранения, либо непосредственно с программами по борьбе с туберкулезом. Я хочу сказать, что мы очень мощно сейчас работаем в рамках дорожных карт, потому что они действительно очень успешны. И с 2018 года, и вот сейчас следующий раунд закончился достаточно успешный. В ходе реализации всех озвученных мной мероприятий мы все равно не забываем о воздействии COVID-19 и подключаем программы по борьбе с COVID. Исследование, которое было проведено в USAID, оно было направлено на то, чтобы провести оценку воздействия COVID. Вот что мы увидели. Что касается того, что да, действительно, здесь совершенно нет никаких сомнений, уже многие предыдущие ораторы говорили о том, что воздействие было просто катастрофическим. Но, тем не менее, мы увидели сокращение амбулаторных услуг на 50-80% во время периода изоляции. И здесь мы наблюдаем, что больше всего пострадали услуги частного сектора.
Patients reported significant reductions both in initiation or continuation of treatment for those patients. Over 80% of our countries reported that TB staff or TB healthcare workers at all levels of the health system were reassigned to provide COVID-19 response. We also saw that over 50% of our countries reported a proportion of their budget, which was originally allocated for TB prevention and care, was reallocated for the COVID response. And we saw that in more than half of our countries, TB diagnostics equipment specifically were repurposed for COVID-19 purposes. And this clearly translated in some of the outcomes that we saw, and Oskar also presented some of these data for our region. But we saw basically in the 23 countries where USAID works, we saw a 23% reduction of TB notifications between 2018 and 2020. And we're estimating that 23% translates into over 1 million less TB cases were notified in the countries where we work. And just breaking down by region, as you can see, Asia region was the most affected region with the 27% reduction of the TB notifications. But in the middle, the yellow graph indicates the 15% reduction that we saw in our Central Asia and Eastern European countries. In response to this COVID, to the challenge presented by COVID, USAID, working with our global partners, really in a collaborative manner, engaged in developing and supporting the global development of a global response to the COVID-19 epidemic, with specifically emphasizing the community level early warning and people-centered response, putting together this framework in terms of developing a rapid detection mechanisms that need to be in place to pick up the early warning signals of TB and COVID in the community. The second element of that response mechanisms was emphasizing the early detection as an entry point for respiratory infections through bidirectional TB and COVID testing at the primary healthcare level with a strong nationwide diagnostic network. Thirdly, it was critical to emphasize the household contact investigation system to be developed to screen jointly for TB and COVID-19, as well as development of TB and COVID-19 advocacy campaigns to encourage communities to actively seek care for their respiratory symptoms and encourage governments to continue to prioritize TB care at the same time as tackling COVID-19. And finally, USAID worked with countries to support them to develop costed national TB recovery plans for domestic Global Fund and for USAID support. The Global Fund initiated the COVID-19 response mechanisms, and all of our countries in the region have applied through that response mechanisms for additional funding to address the challenges presented by COVID-19. But also one of the objectives of the C19RM was to mitigate the impact of COVID on TB, HIV, and malaria. What we saw, however, through the C19 application process was that the mitigation objective was suboptimal. What you see on your screen are some of the initial countries that had applied for the C19 RM funding, and as proportion of those applications, TB was only 4% of the total funding approved. And from our perspective, in a way, this was a little bit of a missed opportunity to attract an additional funding to mitigate the impact of COVID on our TB services. Partially in response to that situation, USAID supported the development of the so-called TB recovery plans in 7 of our countries, which were most affected by COVID-19. You see on your screens those 7 countries, and this table also summarizes what are the main interventions that was supported through these TB recovery plans, mainly under the 2 categories of increasing access to services as well as improving the quality of services across the countries. What COVID-19, the impact of COVID-19 as I already said, and what the numbers have showed, was very significant and devastating on the progress that we have been making on TB prevention and care in the last 5 to 10 years. But also what COVID-19 epidemic showed again was that our data systems were also there were still gaps and challenges in terms of our readiness of the data systems to track and monitor the development of this pandemic. And the WHO colleagues, really kudos to them. We need to recognize the more frequent reporting of TB notifications data, a system that was put in place to have monthly and quarterly reporting of these notifications. Which was made available, and which allowed us to track the impact of COVID on especially on the TB notifications numbers. But what you see on the screen, however, is that some significant elements in the TB cascade. This is just a hypothetical TB cascade, and what you see in the highlighted by the black box there are some of the steps in this cascade, from screening for TB, identifying presumptive TB, evaluating for TB, and confirming TB. All of these critical steps in the cascade, these data are being collected and assessed at the national level, but we do not have a systematic way to be able to collect and analyze those data at a global level, which creates significant challenges for us when we look at the epidemiological and programmatic data, and hinders sometimes our abilities to make timely and significant decisions on how to address the challenges caused by TB and by COVID. In partially also to respond to this challenge, USAID supported the development of what we call the performance-based monitoring and evaluation framework, which was also a mandate which was put forward to us by our administrator then, when he announced the accelerator to NTB in September of 2018. And what you see on your screens is just the framework of that performance-based monitoring and evaluation framework, which is aligned with the REACH, Cure, Prevent, and Self-Reliance components of the TB accelerator, and which has identified a specific outcome, output, and impact level indicators for our TB portfolio. And this is a document that is also available online, and we are expecting to have the Russian translation of this document very soon, in the next few weeks. But as I said, it is really a systematic framework of indicators based on the data that are already being collected by the countries, but it provides a comprehensive monitoring and evaluation tool that includes the 10 core TB indicators that provide the framework for our tuberculosis recovery plans, as well as it includes an extended indicator lists, which are grouped across 14 main TB technical areas. Coming back, however, to the main challenge that is facing our region, and of course that's multi-drug resistant TB, and it continues to remain a public health crisis. The numbers if last year WHO, the global report, started providing estimates not only on rifampicin-resistant TB cases and multi-drug resistant TB cases, but there were estimates included for isoniazid-only resistant cases, estimates across the globe. And what we saw that between the isoniazid-only resistant cases and the MDR and the MDR drug-resistant TB cases, we're looking at about 1.5 to 1.9 million people that develop drug-resistant TB each year. And we know that, you know, the treatment success rate for MDR TB is suboptimal. ASCAR also showed that for XDR TB, that treatment success rate is even worse than for the MDR TB cases. And the drug-resistant TB cases causes a third of the antimicrobial resistant deaths across the globe. And due to the lack of new tools, diagnosis and treatment is challenging for patients and the overall system. And while some progress has been made in development of the new tools and new regimens, we're still facing a very, very significant challenge of drug-resistant TB burden across our region. And finally, just to show that, also highlight the support that USAID has been providing to some research projects that span the continuum from preventive TB treatment to diagnosis, to support to development of shorter drug regimens, both for TB preventive treatment, for drug susceptibility, drug-sensitive TB, as well as drug-resistant TB regimens. And we really look forward to continuing to provide support to this important area for TB prevention and care. And I will stop here. And again, thank you everyone. Thank you for giving me the opportunity to provide this overview of USAID supported activities. And again, thank you very much for everyone for being here. And I look forward also for the next days of having discussions and sharing our experiences across the countries. Thank you very much.
Thank you very much, Sivim. Спасибо большое, Sivim.
Thank you very much, Sivim, for such a comprehensive report presentation. I truly think that the participants do have already better understanding of Global Accelerator, and should there be any questions, I'm just reminding you that you may address your questions to the chat. So I'd like to introduce our next speaker, and this is Andrei Mashniaga, the partner of Stop TB program. And I'd like to say that Andrei, for many years of working within this team, under the WHO team, for many years, he was very much helpful to the whole region, including Uzbekistan, in resolving number of matters, in achieving number of objectives. And so it is my great pleasure to pass the floor to Andrei. And his report, his presentation, Key Lessons from COVID-19 Pandemic, Global and Regional Challenges and Opportunities for Recovery of TB Services to End TB, please. Thank you very much, Nargiza Sadovna. If you may, could you prove that you see the screen? First of all, good morning, dear colleagues. So I'd like to mention right now that in the morning, the director of this program was with us, but then due to technology problems, she was unable to continue being with us, and unfortunately, she was unable to be here personally. So on her behalf and on behalf of all the partnership in anti-TB partnership, I'd like to welcome all of you at this conference, wish you great success, and I truly hope that we will be able to get together, not in the online format, but also directly, face to face. Well, time flies. So 3 years passed when the first meeting at the highest level of UN has happened. So we were so happy, and we are still proud of that. We were able to conduct this United Nations high-level meeting on tuberculosis, and it happened in 2018, 26th of September. So less than, yeah, it is already 3 years past, as I told you, and we are ready to assess, right, the results, to see the outcomes.
So the TB all around the world is really high around the world. I wanted to say here that draw your attention to the fact that the assessment of the Global Fund, which was conducted recently on the mortality rate from 3 diseases to TB and malaria, and according to 2019 data, TB accounts for 62% of deaths caused by these 3 diseases, including TB, HIV negative, and HIV positive as well. So all around the world, there's serious gaps in access to coverage of this essential TB assistance. And in 2019, again, we are using the 2019 figures because since the global report by the WHO on 2020 will come out really soon, within the next month, hopefully, but still nevertheless, in 2019, around the globe, about 30% of all patients with TB patients were not identified. So these are the LTFU, lost to follow-up cases. So about 40% of cases, of TB cases, have been confirmed bacteriologically because of the absence of adequate access to modern diagnostics methods. More than half of the children with TB, as well as more than 60% of the estimated people with TB, they were not with the MDR. The problematic, the serious problems are the gap in prevention of the TB, and because from the highest levels, only 4% are achieved according to UN as far as the equipping the TB prophylactic therapies of the. As was already mentioned, as you all know very well, the COVID coronavirus infection and that have negatively impacted our TB program. First of all, this has to do with the reduction of testing, and as a consequence of identifying TB cases, which unfortunately it leads and it might lead to the worsening of the situation and mortality from TB. So on this very graph on the left side, you can see the tentative assessment, preliminary assessment for 2020 on 84 countries which submitted information reports to WHO using the WHO portal. And according to this data, tentative data in 2020, there was a reduction of identification from 6.8 million cases to 4.9 million cases, as you can see from this graph, which is about more than 20% on the whole. As a result of this, 12 months or more than 12 months of COVID, they've eliminated 12 years of progress, which was achieved in controlling TB around the world. And this research conducted in partnership SOP-TB and with the USAID. Unfortunately, despite the fact that all the calls and TB is one of the for achieving the goals the sustainable development goals by UN, the financing TB, and from the government side, from the international partner side, it is not enough. It's not sufficient enough, and so the allocated financing is only half of their responsibilities or liabilities that the heads of government assumed in their political declaration. The highest level missing from 13 billion, about 13 billion of money required. Only half of that is being allocated around the globe. In addition to that, out of these funds, practically 85% of them are dedicated to the countries with the lower incomes. Again, depends on external funding financing, first of all, from the Global Fund. Again, assessment is of the necessity of funding, which was conducted by the Global Fund on 3 diseases. Showed that out of the total assessment deficiency of $17.8 billion under the latest complement for 3 years, addition for 3 years. So out of this deficit, 10 billion, unfortunately, are given to go towards the TB control, TB fight. So deficiency of funding with TB is really high, as you can see. As for our region now, and let's say European region of the WHO, and in particular Eastern Europe and Central Asia. On this graph, you can see dynamics of this epidemiological situation. And you can see new cases of in 15 countries of the former Soviet Union, starting from 1990s all the way to 2019. You can see the whole dynamics here. And we can see that, as was already pointed out by previous presenters, if on the whole over the past years the situation, epidemiological situation is getting better, but still, if you pay attention, compared to the initial data, initial parameters of 1990s, in 2019, the number of sick people with TB, it was significantly high, almost by 50%, to be correct, by 45% higher than in 1990s, which shows that there's still a work ahead of us in the nearest future, and this tendency are similar to, if again break up by countries into sub-regions, like 5 countries in Central Asia, for example, they are shown with green color, and other countries with different colors. And Russian Federation is shown, it's the biggest, by the way. It's separate, as you can see from this graph. Now, again, here, as all the previous presenters mentioned, there's a problem with drugs, with the drug resistance. TB is our biggest headache. And on this graph, you can see that according to the latest data by WHO for 2019, the percentage or the proportion of as both new and recurring cases, which with the MDR in the European region is much higher than around the world. And if we take the entire world, if it's 3.3% of new cases and to 18% repeated cases, they have rifampicin resistant in European, it's 17% and 52% accordingly, and much higher in any other region of the world. But again, in the European region itself, as we all know, this problem is more or less is expressed by eastern part of Europe, including Central Asia. Unfortunately, on this graph, you can see we'll see the estimates of cases of the MDR or DR for all countries of the European region in comparison. And we can see that the former Soviet Union countries, including countries of the Central Asia, which are shown again with green color here on this slide, they have much more higher loads of DR for both new cases as well as for recurring cases. Again, as for the mortality rate, unfortunately, again in the European region of the WHO, our country, including Central Asian countries, are still not in the very good position. The highest rates are registered here, exactly in this region. So in 2020, the COVID has impacted, as we already mentioned, significantly impacted all aspects of life, including our response to TB. It changed all areas of life. On this at this stage, on this slide, you will see data for average monthly new cases of repeated cases. And this is in addition to what Askal already mentioned presented earlier in 10 countries of the Eastern Europe and Central Asia, which are reporting on a monthly basis, which submitted tentative data to the WHO. And as you can see here, in all these countries, they notice a reduction, significant reduction in in comparison with 2019, for example. Excluding two countries, with the exception of two countries. On this slide, you see the difference between 20 and 2019 and 2021 in comparison with 2020. Same data that again are submitted by these 10 countries. We were thinking that last year, we thought that last year when this whole the epidemic started, when the pandemic started, that in 2021 will be much better, that it will that there were some that the TB services will be reinstated, but unfortunately the situation in our countries has shown quite the opposite, and still even in 2021 compared to 2020 we see the reduction of detection of TB cases by 12% on the whole. But again, two countries, there's increase. On this graph you can see again, out of those 10 countries or Central countries, they submit monthly reports to WHO, and you can see the Kyrgyzstan in the first quarter of 2021, detection of TB cases has improved, situation has improved. So on the reduction, the measures, but then again, these data are only up until March. I think that our colleagues from Kyrgyzstan during the conference will tell us more about the current situation, about the current dynamic in Kyrgyzstan Republic. Despite all pessimistic things that I talked about, I think that COVID has also introduced some optimism. I would like to talk about that in details in concluding my presentation. What are the messages and lessons we obtained from COVID pandemic, and what we can use to improve measures to improve anti-TB measures? First off, of course, I would like to point out. First off, I would like to point out that the COVID has shown the possibility for unprecedented mobilization of the health system for the entire society to tackle this problem for the health systems. As we all know, for the unprecedented involvement of the heads of the governments and the countries in the issues of healthcare. Expansion of the scale of testing in the countries, introduction of events to control the infections that are transferred by air. Also, I wanted to particularly point out that despite all these efforts, I think we can now say that in many countries, I'm sure, including Central Asian countries, the healthcare personnel, they have been really responsible. They have shown motivation. All medical personnel and health providers in this fight and response to COVID. Again, unprecedented things, which also includes the information systems. Also were there. They also helped. They've shown that it's possible, quite possible, to monitor practically on a daily basis, use disaggregated data in real life and publish them, and also and it's good for informing the decision making. What key issues are still there ahead of us in the near future? So to be honest, frankly speaking, I think we can say that if something new was detected, have been detected during this period, which should be utilized to improve the TB fight, I don't think there's nothing new. However, I think that the COVID pandemic has demonstrated that for success, we need to use everything that we already know And we just need to use them intensively and use new methods, innovative approaches and methods. For the key issue is, again, whether or not we want to go back to so-called prior to COVID level to 2019, where, to be honest, they were, even back then, there were huge challenges, big gaps in supporting and access to medical diagnostics, medical care. I think, no, we don't need to go back. I think we need to set new goals, new tasks, expanding access and coverage. And in this regard, the business as usual, such an approach is more, it does not work anymore. Now, what do we have on the agenda? On this slide, I've submitted a summary overview of the main areas of this intensive innovative approaches for expansion, diagnostics, and treatment, and prophylaxis and prevention of TB. Among the priorities are, I wanted to say that we need to expand molecular diagnostics, including using testing, the dual testing, integrated testing, intensify active detection of cases. As for the treatment, as we all know, the further expansion of new treatment regimens, new drugs, both for sensitive, susceptible, as well as for resistant tuberculosis, as well as new systems of providing this assistance, including the digital technologies, and involving the states and societies, and to provide assistance and help. So the prevention problem, it is, I think, rather high in our countries, so it's really challenging. It's a significant problem. At the same time, we know that when the improvement of the epidemiological situation in general, the prophylactics or the prevention plays a key role in getting rid of the TB and it shows the maturity of national programs. Again, here, the use of effective infection control measures, as well as using individual PPEs, play a key role. As for the healthcare systems, COVID-19 has shown the role and necessity to relook, to revise both the requirements, necessities, and the demands by our services, TV services. And for that, as the WHO is pushing forward priorities, universal coverage, for example, or universal healthcare coverages. Again, this TB is one of those, could be one of those good examples which can show how the anti-TB efforts and measures could and should be included in the basic support packages, which will be provided for all people free of charge at healthcare facilities. It's also important that problems of the communities, of key population groups, and the gender rights, that should not be violated. They should be also taken care of. They should be also considered in this regard. I think that the events, the efforts that have been conducted under COVID-19, they've shown the capabilities, capacities of and effectiveness, efficiencies of the civil society groups, and these areas, and these need to be extended, developed further, even more. And at the very last, which is also very important, which I already said, is information system, TV systems are also important. Introduction of video, individual disaggregated systems in real time for monitoring and assessment, which is also important, not only to report back to WHO, but also to take practical measures to which are key decisions. If you allow me, I would like to take one more minute of your time and talk about one of the highest priorities, which is the necessity to expand molecular diagnostics. And I will remind you that these measures are not new anymore, because the gene expert technology was adopted 11 years ago by WHO, but nevertheless, introduction is really slow around the globe. I think it's not more than 20% has been introduced of the TB suspected. They undergo testing with the help of such Trinat or gene expert, and the European Union region is not an exception, unfortunately, which although this is a key priority for Eastern European countries and Central Asian countries with the highest burden of DR TB. On the left side, at the bottom, you see the data, WHO data on the patients. The patients with TB who underwent testing by WHO recommended methods of diagnosis and rapid molecular by the regions. As you can see, our region, Central European region, it looks better than other 65%, as you can see, compared to 28% in the global. However, it's not enough. So we're saying that all TB suspects they need to get this test. And when analyzing data in one of the countries, there's a region in Central Asia. I'm not going to talk about it, but they've identified such things like, which is shown in two graphs on the right side. On the first, you can see that one country there's only two.
Потребности, охвата по стране всего лишь 24%.
So the coverage is only 24%. So the needs are currently covered at this rate. So there was in 2019, but in many areas the rate is way lower. And unfortunately, as I see it in other countries, Central Asia included, as already mentioned by Dr. Parpieva, we need to work on it, and not only to procure and introduce like GeneXpert and other devices, but internet. So we also need to enhance our sputum transportation systems and so on. And to sum it up, I would like to show you some useful resources developed jointly with SNAP-TB partnership. So here you can see links to various materials on COVID and TB, and some of the materials on community and gender. And I would like to remind you, well, this slide is in English for some reason, but I would like to encourage you to check with GDF materials. And so GDF is doing a lot in this area, offering a broad range of diagnostic techniques and TB drugs and consumables for various techniques. And several months ago, we got portable digital systems with AI for X-ray diagnosis. So we would like to invite you to become part of it. So to procure this via government sources. Thank you very much for your attention. Wishing you health and every success in this conference. Thank you. Thank you very much, Andrei. That was very interesting, informative presentation showing new horizons, new prospects for development of this service in our countries, and you've just showed it quite well. Thank you once again, Andrei. And the next floor, well, since we are limited in time, let me switch directly to that. So I would like to give the floor to Vladimir Antonenko from Gauting Supranational Laboratory. So with this lab, with Professor Hoffman, actually, we've been working jointly for many years. We are friends, and before COVID, when we had more opportunities to organize offline visits, Vladimir and other staff members frequently visited Uzbekistan and showed on site, trained as new laboratory diagnostic techniques. And I guess Vladimir's today's message about the global update on TB laboratory diagnostics will enrich our knowledge and will open up new prospects for us. Vladimir? Nargiza Nusratovna, thank you so very much for your introduction. And definitely, I do regret I can't make it offline at this wonderful conference. And 2 years ago, I participated in a similar conference, and actually, I was deeply impressed in terms of the level of its organization, and I'm grateful for the privilege to be able to present the latest update on the global diagnostics. Actually, 2001 is the year that offered us a lot of information on the updates and to be laboratory diagnostics. And if you remember, WHO used this very format of guidelines. And since 2007, various guidelines have been published on liquid culture, automated liquid culture, line probe assays, fluorescent microscopy, and so on. And as you can see, there were quite a few various documents which many people found quite challenging. I mean, to understand, especially those people beyond laboratory diagnostics, and in fact, it was quite challenging even for laboratory specialists, given the number of such guidelines, because some of them became outdated. And finally, in 2020, consolidated guidelines were issued, module 3, and the colleagues before me mentioned that. And these guidelines, in addition to rapid molecular techniques, include molecular technique and AAT. And also the guideline includes the latest recommendations for rapid techniques. And also it makes it possible for specialists, for clinicians to follow the model algorithms given recommendations for different groups suspected for TB. And also there are a lot of clinical details with regards to clinical consequences, and also there is explanation for possible reasons for the discrepancy between phenotypic and genotypic test results. And let me present it in chronological order. And I guess like nowhere else in Central Asia region, we face that problem of discrepancies between genotypic and phenotypic tests. And these tests often misguided us, the clinicians, the laboratory specialists, and we knew that there were some mutations that actually highlighted the resistance to rifampicin, and those mutations could be detected using molecular techniques, and relevant strains demonstrated also sensitivity of phenotypical tests for DST. And of course, that was a concern for WHO. And in 2019, in 2020, analysis of various publications was made, so systematic analysis, and in January 18, so 2021, WHO adjusted its critical concentration for rifampicin for DST from 1 milligram to 0.5 milligrams per microliter. And in fact, our national reference laboratories already switched to this new concentration. And we do hope that there will be fewer discrepancies between genotypic and phenotypic techniques as a result of this recommendation. So as for low capacity techniques, they were on the horizon, and in fact, in 2019, WHO assessed these technologies following several meetings, also with the Global Laboratory Initiative, and thanks to that thorough activity, in early 2021, the document was issued, the rapid advice showing that 4 techniques relying on centralized platforms like high fluoride type Abbott, BDMAX, and Roche were recommended for NCP, and the long-awaited technique C8XDR, which can identify resistance to isoniazid, also to low concentrations, and also to fluoroquinolones. And the injectables, which are less needed now. So finally, this technique was approved by WHO. And the methodology of TrueNAP, along with the widespread test, MTB, RIF, and Ultra, it was recommended, and the specification of this technique is the same. It's in fact the analog of that method, and we are pleased to know that now we have options for our countries, and we can select between 2 different techniques, and it's understandable that be able to understand those techniques and to operate them, we need to systematize them somehow. And the new guideline systematize them. So categories of diagnostic techniques for TB were introduced, and the categories relied on the characteristics and challenges of the techniques and type of detection, meaning depending on complexity, those could be moderately sophisticated techniques, or the degree of sophistication could be low or high, and that's clear. So the easier the technique, the better it fits the conditions of peripheral labs. And as for centralized platforms, they are moderately sophisticated, they are more relevant for major central or national reference labs. And all 4 techniques were included in the updated consolidated guidelines. So the guidelines issued in 2020 were updated and considerably adjusted, since new centralized platforms were included. And now, as you can see, the recommendations include both primary TB detection tests, not only using expert MTB rate, not only TrueNAP and Ultra, and also tests using centralized platforms, so NAATs for detection of TB and resistance to rifampicin and isoniazid. On top of that, the method was included, and also the rapid TB detection technique without identifying resistance, and the new group of techniques was introduced to additionally identify resistance to pyrazinamide. And let us quickly discuss the automated NAAT tests of moderate complexity for TB detection and detection of resistance to rifampicin and isoniazid. So the techniques have demonstrated with regards to TB detection quite high cumulative sensitivity of 93% and cumulative specificity at 97.7%. So as for rifampicin resistance, the cumulative sensitivity was 96.7% and the cumulative specificity was 99%. And as for isoniazid resistance, the sensitivity is slightly lower compared to that for rifampicin. That's understandable because as for isoniazid, it's more challenging, and in fact, they are more scattered across the genome, and that's why not all mutations scattered around the genome could be covered. But despite that, cumulative specificity was one of the highest at 99.8%. As for the updated consolidated guidelines, so they also have the wonderful table which can offer information for balanced decisions with regards to introduction of new platforms, and we are getting information on the number of specimens which could be analyzed over one run during one run of the device, and we also know the average time. So if we take 24 samples, like how much time we will need from sampling to result. And also briefly, the complexity of each and every technique, how many manual steps are envisaged, and how much time each step requires. So all 4 tests based on these platforms became recommended for adults with signs and symptoms of pulmonary TB, and also this recommendation is relevant for primary diagnosis of people living with HIV. It's recommended for adolescents and children based on generalized data on adults. And so far, there is not enough information on its utilization for extrapulmonary specimens. Data are limited, and I guess as soon as countries start using these systems, and when we get good high quality data to detect extrapulmonary TB, I guess the situation will change. Automated NAAT systems, low complexity for TB detection and resistance to isoniazid and second-line anti-TB drugs. Of course, those are long expected, and Cepheid XDR as well. It was recommended for diagnosis of DRTB in adults with bacteriologically confirmed TB, with or without resistance. And in fact, this test is of high value, especially for Central Asia countries, because it offers a rapid detection of isoniazid resistance. And we are all aware that mono-resistance to isoniazid is quite prevalent in Central Asia countries. And it also contributes to the MDR-TB epidemic, since empirical treatment, as we know from publications, empirical treatment of persons with mono-resistant form of TB with isoniazid monoresistance is frequently resulted in treatment failure if empirically we treat them with first-line drugs. Then the recommendation is to use that test also for children and adolescents, people living with HIV/AIDS.
Since we already have data about the similar tests, these are ultra tests and others, we knew that this data and system wonderfully works with no lung samples. The data has been extrapolated for SDR tests. So this was a wonderful advantage in detection of the resistance in the case of diagnostic of non-lung TB. The methods of the line probes has been also added by Genus Scholar system, and this test allows detecting resistance to pyrazinogyl. Unfortunately, it works only for the cultures, so directly from the samples of the serum, we won't be able to obtain good, reliable results. And the aggregate sensitivity is 81%, which is quite a good specificity. In a new updated guideline of 2021, we have finally shown and seen the consolidated concentration of the phenotypical treatment. This information has been disaggregated in the past, and we had a table of the drugs of the second line. And before that, we have received a list of drugs for the first line, and now we have updated the list of the drugs with compliance, the new guidelines, and along with the rapid communique that has been published in 2021, we have updated the critical concentration of clipopeptide. Updates have also covered diagnostic algorithms, which is quite good. And in the guideline now, we have a traceable opportunity of the entire path of the patient through the diagnostics, starting from the detection of the TB, ending with the diagnostics of the resistance and fast method resistance to the drugs of the first and second line. The focus on integrated approach to the patient, reference to the new recommendations on post-screening, and we had more options in the algorithm for the initial test. So except the expert TB, we have entire cohort of the tests, where we now have the test systems of the medium complexity on the nitrification of the neutronium acids, and we have improved the further diagnostics of the RIF cases. We have added methods of detection, the fast methods of the detection by XDR test. So this new method of LPA for identification of the resistance to pyristamide, and what has been expected for a long time now, and you know that we all were talking about introduction of the sequencing. So in 2021, we have published the catalog of mutations and their association to the resistance to the anti-TB drugs, which will become the reference standards for the labs which do sequencing for new generation. And besides the catalog, we also have the information about the correlation with the minimum inhibiting correlations for different drugs. Unfortunately, the work on this catalog did not result in some specifically confirmed mutations and associated with the resistance to new drugs, especially bedaquiline and others. But I think quite soon we will conduct a very serious work on studying the resistance mechanism to clofazimine and betaclamine, including in Central Asian countries. And very soon we will be able to see the update of this catalog. Thank you very much for your attention. Thank you. So we are a little running late by time, but I think Selim will introduce the next speaker. Thank you. Nargiz Mustatovna.
The next distinguished speakers. Paul Sommerfeld is the chair of the TB Europe Coalition Board. And Paul has been involved with the coalition since its creation, when he led on building links between activists in Western Europe and those in the East. Using his original career skills in facilitation, he has led numerous workshops across Eastern Europe and Central Asia. Paul has been deeply involved in global health for over 30 years, first leprosy, then tuberculosis, and also influenza, with a focus on community engagement and advocacy. From 1998 to 2019, he was chair and now executive trustee of TB Alert, a United Kingdom-based non-governmental organizations with programs in India and the United Kingdom. Also, he was once chair of the then Advocacy, Communications and Social Mobilization Working Group of the Global Stop TB Partnership. He has held several UK public appointments, chair of the National Health Service Trust for Mental Health Services in two London boroughs, and as a lay member in the professional regulation of judges, barristers, osteopaths, and pharmacists. And this is a joint presentation to my understanding. Yulia Kalancha is the executive director of the TB Europe Coalition. She's supporting TB-affected communities and civil society in their advocacy efforts towards people-centered TB care in countries of the Eastern Europe and Central Asia region. Yulia is a specialist in European Union law, And since 2011, she has been working in the field of public health and has been involved in the processes related to the widening of access to treatment at the national, regional, and international levels. The main areas of Yulia's expertise are related to community mobilization and involvement of grassroots communities in international advocacy, development and implementation of advocacy activities and campaigns, as well as monitoring of drugs procurement and medical supplies. Yulia and Paul, the floor is yours. Thank you very much.
Thank you very much, Sevim, for the nice introduction. And it is a pleasure for us to be engaging in this conference on the integrated TB care across the Central Asian region. Our particular message is concerning the engagement of civil society organizations, which we continue to consider to be a very valuable resource, but which in most countries could be used a great deal more than at present. I wonder if I'm not sure how to move the slide onto the next picture.
I think just ask.
Okay. So if we could just move the slide to the next slide. No. Okay. Yeah. And we want in this presentation just to remind you briefly of what are some of the things that you should expect that civil society organizations can do for national TB programs. And secondly, my colleague Yulia will give an outline of some of the things that we are already doing in Central Asia through the auspices of the TB Europe Coalition. So CSOs are very used that with their community engagement are very helpful for adding quality and ensuring real people-centered care in TB programs. And as such, they are helpful for achieving the 2018 UN high-level national targets. We're conscious, however, that at conference after conference, lots of speakers say that community groups are helpful and useful, but that is not translated into very much effort to create or find funding that would make their engagement possible. Thanks to the Global Fund, there has been some significant inputs at regional level, but we would still appreciate to see much more engagement and involvement in supporting and using civil society organizations by governments and national TB programs directly. Just remember, civil society organizations, we may be cheap, but we're not quite for free. If we can have the next slide. One of the most interesting new approaches that has been growing in the course of the last year, and which we in TB Europe Coalition are very much engaged in, is developing standardized packages of care that are delivered by civil society organizations. With the move to health insurance models of health financing, that is particularly helpful to the insurance organizations to know what they are paying for. And so you can see right across the spectrum of TB care, there is an engagement, and there are a number of packages which we are in the process of developing and which we expect to publish with colleagues in WHO and PAS in the course of the next few months. And so you see when we talk about prevention, we are looking at packages on awareness raising, group counseling, on patient education, helping patients know what TB is about, and on latent TB infection management when it comes to the non-clinical component. And I stress the non-clinical component. We're not trying to say that civil society organizations are trying to take over medical tasks, but we can be very helpful in supplementing and complementing those tasks. In detection and diagnosis, we can be very active in case finding. In treatment, we can support treatment observation and manage the problems of loss to follow-up and interruption of treatment. When it comes to care and support, there are packages on needs assessment, on psychological counseling, on social support, on practical material support, on counseling and health education relating to matters such as nutrition and tobacco use, and lastly, on post-treatment social support and rehabilitation. We very much hope that these standardized packages will provide an effective mechanism and handle for both more engagement of civil society organization and for sustained funding of them. I'd now like to hand over to my colleague, Yulia Kalancha, who has already been well introduced by Sevim. Yulia.
Yes, thank you very much, Paul. And we see that CSO can wait a minute, sorry, I will switch off. We see that CSO can provide direct services in the TB response, and this is recommended by WHO and by many strategic regional and global documents. But the role of civil society sector is not limited to this, because their role is also important in the process of coordination, planning, management, communication, and social mobilization for greater partnership and to generally end TB. And these aspects are considered and are prioritized through national strategic plan in many countries of the region. And we can say that today's strategic planning already looks much more broadly at helping a person affected by TB rather than simply providing TB care in specialized medical institution. And through people-centered approach in TB, we do not treat the disease, but we pay attention to the needs of person, and the person can have whole range of needs, both diseases and condition. And these needs are, for example, to be empowered with information, stigma and discrimination, or helping to overcome barriers related to human rights and other issues. And in all this, the role of civil society and community can also be very significant. On the slide, you can see a number of tools that have been developed specifically to strengthen the engagement of civil society organizations and communities, and to overcome non-medical barriers that people with TB are facing. All of these activities are recommended to be community-led. And with this, I would like to give a few examples of community-led activities besides service provision that countries and national TB program can benefit from engagement of civil society and communities. And as Andrea Mashnyaga mentioned in his presentation, that globally health systems miss millions of people affected by TB because of barriers to health services, human rights, violations, stigma, and a lack of access to supportive services. And in response to this, the One Impact tool was developed, which is now implemented in 6 countries of the region, such as Ukraine, Kyrgyzstan, Kazakhstan, Belarus, Tajikistan, Azerbaijan, and Georgia. And this is a digital platform, basically an application made up of 3 tools that work together to provide a comprehensive community empowerment, community engagement, and community-led monitoring solution that puts people at the heart of the TB response. And through these tools, people are empowered with information and ways to report challenges they are facing with. Data can be used to respond immediately to people's needs. These tools also aim to provide TB response to support and help national TB program to see systematic and social challenges people are facing with and impact their lives so that the systematic challenges can be improved and be more reactive to the needs of people with TB. The app implementation also has allowed the country's team to came up with a number of solutions to improve national TB program. For example, to increase the training effectiveness, they began to organize smaller groups of participants to enter into partnership with doctors in medical institutions who conduct trainings on an individual basis so that they could pay more attention to each patient whenever possible. In some countries, they began to conclude agreements with patients to obtain the right to transfer their confidential data from medical institutions. Also, countries began to practice telephone consultation for patients and involve doctors as expert consultants to promote the application. And there are many more others improvements thanks to this one impact, a tool led by civil society organization. Another good example is that from 2016 to 2025 countries in ECA region like Georgia, Kazakhstan, Tajikistan, Kyrgyzstan, and Ukraine have conducted community right and gender assessment using Stop TB Partnership individual or integrated CRG tools. And some of the countries had made more than one community-led assessment that contribute to a better understanding of barriers faced by particular key population and human rights, legal system, stigma, and other gender aspects in TB response, and develop reports aimed to assist countries and NTP in particular in transforming the TB response to be equitable, right-based, gender transformative, people-centered, and strengthen the national TB policies and funding application to the Global Fund. It also presents differentiated fundings on stigma and discrimination, gender, financial barriers, and human rights, and propose specific ways forward in each of these domains. For example, this CRG overview found inequity in how different patient groups accessed and remained in TB care, and that the consequences of TB were more catastrophic to some population groups than to another. For example, that women who use drugs and women with a history of imprisonment from these key populations are the most vulnerable and stigmatized. And such findings and data will be used by in-country stakeholders, civil society, and activists engaged in-country dialogues as evidence to guide their discussion, and that the recommendation will be translated into activities and budget. Next slide, please. So what TB can offer to countries to support civil society organization and communities so that they can be more effective and meaningful engaged in the national TB program? As Paul already mentioned, now at the level of ECA region, an important working document has been developed by civil society partners together with WHO Europe. This is a standardized package of supportive services in the field of TB. Depending on the budget availability and country interest, TBAC may provide technical support for civil society and community meaningful engagement in TB response. So we can support the practical implementation of this standardized package of community-based TB supportive services and share experience of its implementation from other countries, as now 9 countries of the region are at different stage of its implementation, and there could be different ways how to do it. Other thing that we can support is the national dialogues that can mobilize key populations and decision makers to promote cooperation and bridging the gap in access to TB services. This is an advocacy event and learning by doing opportunity for community and civil society organization. As well, mentoring programs can provide a unique instrument for community leaders and activists to critically reflect on management and leadership skills, which would have a direct impact on service provision in general. Also, we can provide training for mentors to enable local capacity and skills to grow up and stay in country as a part of the strategy that aims to local community ready to take an action. Also through capacity building activities like, for example, training on soft skills, exchange of experience with the involvement of decision makers during CRG workshops and other training, we can further support practical implementation of knowledge gain during dialogues, including development of practical evidence-based recommendation and advocacy activities. The CSO and communities will be ready to initiate and conduct effective dialogue with stakeholders without external assistance. Also, we can support countries during assessment on the use of multi-sectoral accountability framework for TB using Annex 2, which specifically related to civil society organization meaningful engagement. And this MAF-TB tool is recommended for implementation for all countries by WHO and to NTB. This support at the national level may include, for example, research capacity building, as when civil society and communities affected by TB are involved in the baseline MAF-TB assessment, there should be specific capacities to support this process. TBEC will propose a new universal protocol which can be adopted by countries for collecting quantitative and qualitative data that complements the baseline MAF-TB assessment. And this protocol also includes the guidelines for organization, the process, and complementing Annex 2, and provides additional data collection tools related to qualitative and quantitative method to measure data and suggest roles and specific tasks for assessment team members and other documents to support and launch MAF-TB at the country level. So I think I will end here, and Paul, please, your final word. Thank you very much.
Thank you, Yulia. Just to close our presentation, I would just stress that, first of all, TBEC, we already work with partners across all 5 countries of Central Asia. We believe that working with civil society groups, NTPs, are in a position to greatly increase the quality, the real people-centered nature of the programs that you provide. And we would hope that you will be ever more creative in finding ways to engage civil society organizations and make use of the skills and the strengths that they have to help the good work that you are doing. Thank you.
Thank you very much, Yulia and Paul, for this great presentation, and thank you for being keeping on time. This was our last presentation for the morning session, and we had very interesting presentations, very rich data information, as well as experiences that were shared this morning. Unfortunately, we're also quite behind the time, and I know for some of you that you are there, we're keeping you away from your lunch. But I will turn it over to Professor Nergiza Porpieva for her final words as well. And just to say that in terms of, there were some questions that were answered to all either in the chat or in the Q&A session. But if you haven't had your question answered, please repost it again. Thank you very much.
Thank you very much. And да, на самом деле, Севим, вы
Yes,
совершенно...
thank you very much, Sevim. You are exactly right. We've received a lot of very comprehensive and quite novel information, which will be of an interest for everyone, for all the participants. And it was quite fruitful morning, I'd say. We've listened to all 6 reports. The only thing is that welcoming remarks were quite lengthy, I would say. So everyone wanted to report and a lot of interesting information was there and we were not able to interrupt. So we are late for 50 minutes, almost an hour. So once again, I'd like to emphasize that. First of all, I'd like to thank all the presenters, Sevim, my dear colleague, co-moderator, and I'd like to say the following. So I'm truly hopeful that, first of all, should there be any questions? Yeah, we actually were planning on having Q&A session, but please do it in writing. So if we see them in chat, definitely later on, we will find time to respond to them. And the presenters, should there be a targeted question to one of the presenters, so we will pass it on. So my proposal is to have a break, of course, till 1:20. So let's have it for like half an hour. So because for the countries which will have to share their work of NTP on the impacting and combating with COVID in Central Asian countries, so we will split them by hours. See? So please, so, well, 1:20, that's the time for our next session. Thank you.
Уважаемые коллеги, я надеюсь, вы смогли передохнуть. Жалко, конечно, что вы не в Узбекистане. Мы бы вам предоставили нашу и очень вкусную кухню. И, конечно, у нас сейчас пора созревания дынь, и винограда, ну, изобилие, конечно. Но я очень надеюсь, что в следующий раз мы сможем провести и оффлайн, и тогда мы, конечно, добавим к нашему радушному приему еще и нашу кухню. Но я думаю, что нам надо приступить к
Oh, I
следующему.
truly think that we have to start our next item of our agenda, and we have the presentation from the countries, from the NTPs. Since in Kazakhstan, Malik Moldabekovich has an emergency almost situation, they have a visitor there, so I'd like to pass the floor to my colleague, the director of Center of NTP in Tajikistan, Asledin Rajab Zada, please. Tajikistan.
Уважаемые коллеги, кто у нас находится сейчас в
Dear
онлайн-связи,
colleagues, those who are online, we have technical delay because other countries are joining us. Do we have? Yeah, who exactly do we have? Tajikistan. So not to have any delays, once again, I'd like to emphasize that the first floor will go to the head of NTP Tajikistan, Asledin Rajabzada. Please. Good afternoon, esteemed colleagues. Do you hear me? Do you hear me well?
и видно. Добрый день.
Yes, and we can also see you. Thank you, esteemed participants, the organizers of Fifth International Conference on Integrated Tuberculosis Control in Central Asia. It is my great honor to be part of this conference and to present our report. And thank you so very much that we have so many participants from a number of countries. Even though we're far from the steering committee and we're here in just online mode, but still we feel that we are part of this event because we think that even virtually we are well communicating with each other. So In April 2020, we've had first case of COVID-19 in Tajikistan, and based on 30th August 2021, the number of total COVID cases reached up 16,778. So 0.2% of total population of the Republic of Tajikistan. What had happened in the beginning of pandemic? Pandemic has impacted, of course, unprecedentedly to the public health care due to a lot of risks and barriers in providing main medical services, healthcare services. There were high risk of disruption in supplies of basic medical drugs and also medical materials globally. A concern of number of people to seek healthcare help based on the COVID-19 was obvious. So that's why the whole system has weakened, and the access to clinical services has been reduced. And also we had problems with vaccination, etc. So as for the capacities, we only had 10 laboratories which were capable on doing PCR. By the assessment of WHO, we're supposed to have 25 of them. So we were lacking also a number of tests that impacts the burden, of course, additional burden to the medical personnel. And that was quite obvious. A lot of financial and medical resources and human resources has been diverted to COVID service. Sudden need in financial support was quite obvious. So we started to be faced with financial deficit in the healthcare. Suddenly, we started to have a lot more patients all over the system. So that almost jeopardized the whole system. Sudden increase of burden on civil society organizations. So the efficient implementation of their activities has been also jeopardized. The impact in combating TB, well, that was also obvious, and that impacted global measures combating TB. And we've decreased screening capacity, and also there was obvious worsening of that capacity. And then we were also unable to detect TB timely, reduction of patient enrollment for treatment, efficient clinical management of TB cases due to self-isolation. And of course, exacerbation of TB stigma and discrimination. So immediately we were able to establish a working group to involve our partners to improve the situation with TB. We've developed the pandemic response plan within the TB service. Then we started to strengthen the infection control in the context of pandemic and development, and also the proper means to support our patients. So besides the order of TB to all TB centers on management has been provided with we had to perform our task in covering all the TB centers. So we had to provide all anti-TB drugs to patients for a couple of months to cover them completely. So that was the way out, of course, and also TB treatment mainly at home. This is what happened. So under the control of the volunteers and social workers. So we had a lot of partners helping us. Then provision of video duty and family duty to committed patients. Then we've also developed mobile phone-based tracking. So development of temporarily TB diagnostic algorithm. This is what we've done in order to support our system to properly provide the resources. So, of course, we had all our borders closed. So that's why traveling was not possible. We had travel restrictions. So, of course, we started to lose the opportunity at the treatment at the initial stage. So we started to have late referrals to anti-TB services. So, and also there was a lot of delay in diagnostics because we were lacking diagnostic, not only like diagnostic equipment, but also supplies for ATBD. So then we were also unable to cover everyone. And later on, we started to have late addressing to the TB services during pandemic that brought down to the increase of the numbers of deteriorated TB.
Of the TB patients taken for treatment decreased by 12.3% in second quarter of compared to the second quarter of 2019. Such a reduction in the TB cases poses high risk of sudden inflow of high cases of TB incidence in the coming years. In this slide, we are showing the incidence rates and mortality rate and success rate for the period 2010-2020 for the Republic of Tajikistan. As you can see, in 2020 compared to 2019, I want to draw your attention to this very slide. The incidence rate year after year was decreasing, has been decreasing by 1.2, 1.5 parameters, but we have a sharp decrease of this. There's more than 15 indicators in 2020 compared to 2019. The indicators, I mean. So this is in comparison with 2019. So the mortality rate is at the same level. This rate indicated just like in the previous years during COVID-19 pandemic did not affect the TB services because in 2020 compared to other years in Tajikistan, as you can see from this slide, and there's an annual reduction of by 0.2, 0.5, 0.6 indicators. Success rate again with treatment success rate again has reduced by 2 indicators, and again you see here by the regions as well the incidence rates by the regions in Tajikistan. But compared to DR TBs, here you have by months we're shown by month compared to 2019. Among all other cases in January of 2020, it's not a big reduction of incidence rates because like I said, starting from the second quarter of we registered first cases of COVID-19, and starting from the second quarter we started there was a reduction starting from April. You can see from the slide compared to the April of 2019, there's a sharp decrease in the incidence rate by 160 patients. In 1 month, there's been a reduction in incidence rate. Again, in same thing in the first quarter of 2021, there's been a reduction of cases, TB cases, and on annual months, there's a decrease of the incidence rates in TB. Now, DR TB treatment, again, we've seen some reduction here again compared to previous years, but there's been measures taken to address that, and we started to actively work in that there. So currently we have both new cases, MDR cases. There's been sharp increase of MDR cases, and in 2021, as you can see here from the slide, in August, after our analysis that we conducted, we noticed that there's been approximately increase by five indicators of incidence rate compared to same periods in 2020, and we're hopeful that if it continues, we will be able to reach those goals that we were set. Possibly there's maybe USAID, in accordance with the UNDP, they've conducted a modeling research assessing the potential impact of COVID-19, the epidemics, to TB program in the Republic of Tajikistan. By modeling, we assessed the growth of incidence rate and mortality rate from TB within the next 5 years. We've modeled two scenarios. First being the moderate outcome of TB services, in which the entire TB services they are recovering to normal state within 4 months, starting from November 2020. In other words, there is no so this is a blue line here, and scenario number 2, it's interruption where the tendency that we can observe in November 2020 is going to continue another 5 months. In other words, until the May of 2021. This is the red line on the slide. If you can see it, this is right here. This is on the slide. It's shown on the slide here. In conclusion, I want us to say here that even temporary interruptions in the work of TB services can significantly impact mortality incidence rate in TB in the Republic of Tajikistan within the next couple of years. But never, however, any efforts to recover the lost undertaken right after these interruptions that can contribute to improving the situation and bring to long-term positive results and help with these interruptions that have taken place in the past. I have on the previous conference on those things that we were supposed to do according to the requirements from the previous conference, and on the resolution as well. So what we were doing, so we developed and approved by the government of the Republic of Tajikistan new national program to protect the population against the TB for the period 2021-2025, increasing the financial resources which will be effectively used to implement TB program in the Republic of Tajikistan, ensure the full coverage, qualified services for prophylaxis, for prevention, early treatment, and dispensary follow-up, including the TB services. There's 56 gene expert equipment, 7 digital X-ray, 7 mobile mobile vehicles that we have in Tajikistan. Improved access to diagnosis to TDR, TB, and NMD, using new methods starting from February 2021 in the regions of districts and regions of Uzbekistan. We actively we are widely using new drugs with the shortened regimen for all kinds of DRTB patients with the necessary follow-up. Within this operational research, starting from 2020, we are using new treatment regimes against DR, against MDR, such as BIPAL and MCRL modified shortened injection treatment regimens. Right now, we're talking about 60 patients that have and 16 patients are taking BIPAL. They're getting BIPAL treatment. So the country has developed and approved a number of legislative documents and new approaches to prevention and the timely diagnostic and treatment of TB in children. We've extended the methods of inducing and procurement of drugs for the children and for the diagnosis to treat TB. We are improving the immediate measures to integrate necessary services for the patients with the mixed infections. The country is using the best advanced practices involving the civil society in implementing anti-TB events. We're focusing on vulnerable groups of population, including migrants, prisoners, ex-prisoners, and HIV people living with HIV, considering the human rights and gender aspects as well. Thank you for your attention. Thank you again. If you have any Any questions, please? You're welcome. Thank you very much, Aysuluddin Saidburkhovich, for very contentful, very informative presentation, and also for the progress in fulfilling the resolution from the previous conference. We will take that into consideration when developing resolution of this very conference, which will be, the draft will be distributed among all the participants of today's conference. So let's switch to the next presentation, which will be given by the director, head of the National TB Program of the Republic of Kyrgyzstan, Professor Karatay Madamir Musayevich. Please, you have the floor, sir. He's not with us. Hello, good afternoon, dear participants of the 5th conference. Allow me on behalf of the National Physiology Service of the Republic to welcome all of you on this very conference and express gratitude for the organization of this very forum. As was already pointed out, it's indeed the impact of COVID-19 to fight against TB in Republic of Kyrgyzstan. So the Kyrgyz Republic is the smallest in terms of population in the Central Asian country. So that's why almost 6.5 million people, and the territory is only 200,000, about 200,000 square kilometers in Kyrgyzstan. And the pandemic 19, indeed, for the first time, on the 18th of March, there was a first case registered. COVID-19 was registered for the first time. There has been very first 3 cases at the end of March, from in the period of 18th through 23 March. Just like in other countries, we also announced the emergency situation, as you all know. So here we're talking about the restrictions for movements, patients that could not come to medical or other institutions, but the patients, TB patients, this is a high risk. This was complicated during COVID-19 because they interrupted the TB treatment, unfortunately. But according to the order by the Minister of Health of the Republic of Uzbekistan, many departments, many territorial hospitals, TB hospitals, private of the National Physiology centers, they've been requalified to respond to COVID-19. Even the laboratories, since April 2019, they started testing for COVID-19. We all know that in 2020, the highest peak was in July, which we call the very first wave. The second wave was in November of 2019, and currently we have, starting from 6 September 2021, 478,000 and more than 2,566 deaths. Unfortunate. This is very unfortunate. Madam Musayevich, please check your microphone because we stopped hearing you, sir. Please check your microphone. Please turn on your microphone, sir. You muted your microphone, sir. Can you hear me now? Yes, we can hear you. Apologies for that, apologies. Again, what measures were taken? Here, again, number 1, changes to organization of the treatment, enhancement of the infection control measures in the healthcare facilities, support to patients, and monitoring of the treatment, and improvement of the awareness during COVID-19. Lost them again. We approved by the order by the Minister of Health, as my colleague pointed out. We also have anti-TB drugs for 14 days. So direct control of treatment, different types of treatment control, and here we included the among the family members and also public supporters, the online TB consultants to provide continuity of monitoring and treatment of those patients that are undergoing treatment. The most important issue was the infectious control of the TB in the organizations. Again, as was already pointed out by several times by previous speakers, because of COVID-19, we revised the internal algorithm on infectious control. We approved a new procedure for working in red zones, reference laboratories for testing for COVID-19, with measures of infectious control, and the personnel of TB system within TB system and TB services, they've trained the different measures, and they have the PPEs as well, and support to TB patients and events to improve the awareness and inform. This was one of the main tasks. Here again, there was a social support that by the nurses and the Red Crescent. Social workers also helped with support from USAID. We gave out product packages. We also mobilized local communities to help the TB patients. We distribute information about through informing, talking about symptoms through websites, social media of the Ministry of Health and Social Development, National Phthisiology Center, Fund of Compulsory Medical Insurance, and many other partners. In addition to that, the official information channels on TV, radio, and mass media were also used to increase awareness. How COVID-19 impacted to TB assistance and TB service? Yes, it's true that there's been a decrease of diagnostic or microscopic research done at the PHC level. There's been a decrease of the volume of sputum through central transport system. This is we're talking about National Republican Reference Laboratories from all treatment of tuberculosis and management of cases. Number of patients has decreased. I mean, because there's been a very few number of patients at the hospitals, and support to patients in regards to the adherence to treatment. Again, as we can see on the statistics dynamics of the mortality incidence rates in the Republic of Uzbekistan over the past period has a tendency for reduction. According last year, as you can see on this slide, for 2019, 2018, there's been a sharp decrease, 32.2%. This is the incidence rate that tells us that this is related to I will talk about it later. This has to do with the low approach rate by the patients for the TB treatment and for low turn-up at the laboratories. The impact of COVID, as you can see here, here we have in the first quarter, red line, TB, and the blue is COVID. In the first quarter there were 262 cases, and it was the highest peak in the third quarter. This was July. Here we have 39,000 cases, 622. Here we have the similar reduction in the second quarter by 40%. By 42.2% in TB detection, and in the third quarter by 50.3% reduction. As we can see, compared to 2019, 2018, these tests conducted on DR TBs and using the anti-TB drugs, you can see we can see the sharp decrease in the second quarter. Again, 47.6% for DR. And in the third quarter, 45.6. And as I already mentioned, we had a second wave, which was in November. Again, here we see a total number of 39.4%. If you look at, here, so we have in the third quarter, so there's been a decrease by 63.1%. COVID impact to TB services. These are the data on the quality of TB services done by under the USAID and TB in the first quarter of 2021. We had 289 institutions. We're talking about different primary, secondary, tertiary, and depending on the town or village, we covered the entire country. We had a questionnaire of more than 1,000 medical providers in 7 regions of Kyrgyzstan, and we interviewed 740 patients. What data we have? So as you can see here, we have 60% of institutions in the entire country reported that COVID-19 impacted the TB services. 33% they reallocated TB finances to respond to COVID, to buy the PPEs. 63% of institutions, they've moved the personnel that were initially providing to TB to respond to COVID. Here I wanted to mention about the personnel that was used to the maximum in responding to COVID. So they are supposed to now respond to COVID. Again, 61, so we've converted the best to COVID, and 48% for DR, TB, and 55% for NDR, TBS. 11% of cases, institutions, they reported the deficiency of TB drugs before the. Here we're talking about deficiency of first-line drugs. 11% to Revan institutions.
Ten percent of facilities indicated that they had deficit of line drugs and second-line drugs, 11% and 24% respectively, and actually 78% of facilities indicated that they were engaged in contact tracing, and it also produced its impact. And 39% of facilities noted decrease in TB cases enrolled in treatment since the start of COVID-19 pandemic, and 58% is the reduction in the number of patients under control by health facilities. And as for the highest reduction is the primary level, 61%, and the secondary level, 40%. So as you can see, we have 280 patients. So it's the average daily number of patients with TB undergoing treatment or treatment monitoring before COVID-19 pandemic. So, and the reduction at the primary level is from 6.4% to 2.4%, and at the secondary and tertiary level, the reduction is quite comparable. And as for the infection control, 57% of facilities enhanced their infection control techniques in response to COVID-19, and 98% of facilities reported adequate number of personal protective equipment, mostly at the tertiary level, and 70% of facilities regularly test their personnel for COVID-19. So the conclusions are the UTSA results show considerable disruptions and TB service operations due to COVID-19 in all areas: diagnostics, treatment, TB contact tracing, and so on. And the initiatives of the NCP in response to COVID-19 in 2020 made it possible to mitigate the impact on TB and help the patients continue their treatment. And most of the initiatives continued on a sustainable basis, like online counseling, online support groups, and enhanced infection control. So what we suggest is we need to enhance anti-TB interventions via integration with approaches developed against COVID-19. Train the population and health professionals in cough etiquette, ventilation, wearing masks, and then we need to ensure a triage of visitors in parallel screening of contacts, and then we need to enhance the approaches for active TB detection, both at the facility level and at the community level. We need to introduce the FAST strategy at health facilities, mostly at PHC level and general hospital. And then we need to enhance contact tracing activities, strategic planning for a TB laboratory network, ensuring access to high quality laboratory diagnostic techniques. And here, in fact, our national reference lab is working. And what I mentioned before is transportation. So we plan to open the laboratory in the south, so people don't have to go to Bishkek. And so tasks could be done in Osh city. And then also we plan to ensure development of new programmatic information programs based on the priorities for TB care. and then further expansion of TB case management. So high quality transition to short-term oral treatment regimens and adherence treatment, and also we need to enhance TB preventive treatment, especially for people living with HIV and children under 5. And let me focus on the interventions conducted in Astana, and as mentioned before by our colleague from Tajikistan, the resolution mentioned above is being implemented, and you can see that at least 90% of detected cases are being treated successfully, but unfortunately in recent years, as I said before, it's due to the impact of COVID-19. And we actually have hope that we will finally reach our targets. And as for financial resources, so we are making efforts to ensure self-sufficiency. And as for procurement of second-line drugs, well, we procure first-line drugs from the state budget, and now we are planning to do the same for the second-line drugs, and that's for access to prevention, early detection, as for access to dispensary observation. So now we are referring to not only mobile teams, but we will focus on prevention and case detection. So as for border control and migrants, so we border on China, Uzbekistan, and other countries, and so we work closely with our colleagues Tajikistan, Uzbekistan, and Kazakhstan. So as for pharmacovigilance, it's in progress, and also we conduct operational studies. And in that regard, the Astana resolution is a result of the 4th International TB Control Conference. So as possible, we are implementing it now. Thank you. Thank you very much, Madamin Musaevich, for the information provided, for this opportunity to take a look at Kyrgyz experience. And in the context of pandemic, definitely there was some impact on TB detection in the region. And the next presentation will be made by a representative of Kazakhstan. Now I would like to give the floor to a representative of NTP of Kazakhstan. I guess Malik Moldabekovich will not be able to present it. So please introduce yourself. Please switch on your camera. Dear colleagues, Kazakhstan got disconnected, and that's why I suggest we finish the plenary session, and we will hear from our colleagues from Kazakhstan after the results of discussions and sessions are presented. And now I invite you to sessions. Please follow the link you have and go to your respective groups. So the sessions will start in 5 minutes again. To make it convenient, so you could follow your links, and then at 2:25 parallel session will start. Once again, I would like to extend my gratitude to our facilitators, Dr. Sevim Ahmedov and Professor Parpieva Nargiza Nasratovna. And with your permission, this is the end of the plenary session. Thank you.
Уважаемые коллеги, добрый день. Пожалуйста, подтвердите, если меня слышно.
Dear colleagues, good morning. Please confirm that you hear me. Yes, we can hear you. Thank you. Welcome everyone to our first session, which is related to comprehensive approaches for identification of the TB. And I would like to express great thanks for opportunity to moderate this interesting session. And before we start with the first speakers, I would like to mention some organizational issues so that we avoid any technical problems. I would like to ask all speakers to prepare your presentations in advance, and before your turn, please turn on your video and share screen functions. This session I will moderate together with Mr. Paul Sofferfield, who is a European Coalition on TB leader, and I'm from Tajikistan, Ministry of Health. Our first speaker, and with great pleasure, I would like to give the floor to Evgeny Kagachi, who is a lab expert, microbiologist, who from the 2001 presents a sub-regional laboratory. He worked for almost 12 years in Belarus in the Republican Scientific Practical Session of Pulmonology and Pediatry. He was a laboratory staff and the head of the laboratory. And the main areas of the work of Evgeny is strengthening of the laboratory network in Central Asia, Belarus, and Ukraine. And the activities that he covers basically are practical training, development of the laboratory quality management systems, organization of the lab work, support of many development of strategical plans. And he also contributed to new algorithms introduction approved by WHO. Please, Evgeny. Hello, dear colleagues. Hello, Maka. I'm happy to see you. I'm happy to welcome all from Bavaria. And I would like to talk to you today about the future of diagnostic algorithms for TB by using the new technologies and new tests which are currently approved by the WHO. My presentation is very much linked to the presentation of my colleague and friend, Vladimir Danenko, who provided this information in the plenary session. But for us to understand the capabilities of the and diagnostic status of the new algorithms, I would like to dwell upon the main provisions so it will be clear for us to then move to diagnostic procedures. My entire presentation is based on updated, consolidated WHO recommendations, which have been first published last year with updates in summer 2021. For the first time, we have introduced the classification of technologies. If in the past, diagnostic methods were divided roughly to routine phenotypic methods and molecular genetic, currently we distinguish technology blocks because in each block there could be different technologies and tests approved. So we have now a new position in the class, as Vladimir talked about. These are the NAAT tests. With a moderate complexity for detection of the TB and the resistance to rifampicin and isoniazid, and low complexity automated NAATs for the detection of resistance to ezinamide and the second line anti-TB drugs. So many technologies are preserved and still urgent. For us to understand the status of this test systems based on the system, let's look at the groups of methods approved by the WHO. This is a primary diagnostic test with determination and without determination to the drug resistance, and further diagnostical tests for identification of the additional drug resistance. Traditional diagnostical tests are still preserved, and testing of the drug sensitivity, both on phenotype and typical. Primary TB diagnostics. So these are tests which are recommended with the determination of the drug resistance. 3 groups, 3 areas which are well known technologies of expert and TrueNAT from India, and automatic medium complexity. And diagnostic tests without determination of the drug resistance, these are TB-LAMP and LF-MAP. I will not talk too much on the RAF technology, which has been introduced and used in the Central Asian countries. So we know the target groups and materials used. This is our main tool in the primary diagnostics. Last year, we have recommended additionally as an alternative primary diagnostic test TrueNAT, which is based on micro PCR in the real time. And we can identify the MTBC, and what's a drawback is that we can conduct only one test at one time, and only when we separate DNA of the MTB, we can identify its resistance. What has been discussed last year and approved now at the level of the WHO, what is called automated NAATs of medium complexity. So what unites them by functionality? So by function, they're all the same. This is the detection of the microbacterium TB and identification of the resistance to RIF and NMT. From general WHO recommendations, as far as this group, we can know that it is recommended to conduct tests of the RIF and INH before the sowing of the cultures. Briefly about each system, Abbott Molecular has 2 tests, 2 platforms. High sensitivity for analysis, the limit of detection, up to 24 samples within 24 hours. MTBC and 24 sensitivities could be determined. The similar device, BD-MAX, this is the MRT PCR, so we can do 48 samples within 8 hours, very good sensitivity, We use mainly lung samples. Real company Roche produces two technologies with big number of the capabilities for tests for 300 up to 384 samples a day. Some laboratories do not do so many cultures, but machines can do the tests. Very good analytical sensitivity has been announced. It differs from the drug, but it is sufficient to identify it with high precision. And the system number 4 is the Bruker-Hein Life Sciences, which is called fluorotype, 2 tests, 2 different tools with different capacities. Everything is the same. Respiratory samples, high analytical sensitivity, from 12 up to 96 samples in one device within 3 to 4 hours that you can test. Primary diagnostic tests, this is where determination of the drug resistance did not change. They're the same. The same LAMP test, which is alternative for microscopy laboratories. This is a point of care. This is a very low-level primary degree, and its restriction is that it does not determine the sensitivity or resistance, and microbacterial LAM test for patients. For expanded drug resistance, this is something which is very urgent for us, with the view of the resistance to RIF in our region. So these tests are of principal importance. These are diagnostic updates of the Cephine company. These are XDR expert. The method of linear probes and LPA for pyracenta method is added as well. On XDR, I will not dwell upon too much. I like the line of the drugs it can test. These are the measured drugs of the second line, which are very important for the updated methods of treatment. High analytical sensitivity. And up to 5 tests a day each unit can carry. It's pretty good. From general recommendations of the WHO, this test is recommended to identify resistance from INH and FQ, which is very important for phenotypical treatment. And if it identifies RAF's resistance, it can identify the resistance to ethionamide and proteonamide to conduct sequencing NHA if this technology is available in your labs. On the method of the linear probes, I will not again talk too much. It is quite urgent and accurate, and it overlaps the technology of Cephidis, expert XDR, which overlaps the information about the results that you can obtain. And what's new is Japanese company Nipro, which produced the tests on LPA, which will help us after certain of time as a main factor of time and precision. Also, it is recommended to do before the FTLH, traditional diagnostic tests. So microscopy has phased out as a diagnostic test, and the main recommendation to all the countries is to switch to the regular methods, which improves quality, efficiency, and time. So microscopy can be still used as additional tool while culturing and as obtaining the additional bacillary information. And for us, the special importance is given to phenotypical ways of culture with liquid and nutrition serums in order to identify the sensitivity. As you know, we have updated terminology due to the update of the treatment schemes of the MLRTB. So mainly it's about the resistance to Tori, and in the case of MFX, it also adds another resistance to it, one of these types of drugs. As far as all these novelties, for the lab service, in vitro, as suggested in the following list of anti-TB drugs and critical concentrations using which we identify the sensitivity. Therefore, the FTLH still maintains its reference standard. So all the molecular methods are demonstrated indirectly, but would like to see it in life, whether indeed this mutation or no mutation happens. Wide range of the anti-TB drugs and phenotypical TLH, I think, will continue holding its position to analyze the results of the tests. Future that we now made closer to us. This is using of sequencing technologies. So there are different technologies like target sequencing and full genomic sequencing, and WHO promises by the end of this year to provide its more specific recommendations about the profiles of those technologies. There are many in the market, companies which fight for the market. There are different approved technologies which are being validated, but what makes them similar is that they don't have the approval by WHO for TB. So we hope that it will come out soon. The main problem, as we have already mentioned, is standardization of the list of mutation and interpretation of those mutations. The first attempts have been made since 2018 and 2021, where we have created good catalogs of mutations, but it requires more detailed data for interpretation by clinicists and the laboratory staff. WHO does not recommend serological methods. Tests of amplification of nucleic acids for monitoring of treatment. So as doctors do not want to use it in treatment, it's better not to do it because they can get confused. LAMP test for diagnostic of active tuberculosis is not recommended as well. And active tuberculosis, whether it is lung or no lung, is not recommended as well, but it is recommended to identify or detect latent infection. So you should clearly know why you are doing the test. There is already a recommendation on the latent TB infection. So lab networks can start using it. On this slide, you can see the picture or depiction of what technologies that I have listed are recommended by the WHO in organizing the lab network. So at which level, what technologies could be used, central, regional, or provincial, and their functional capabilities. So as far as algorithm, primary algorithm, it hasn't changed since last year, basically. The molecular diagnostic tests are primary. You don't see any microscopy here, only molecular, and they are present in all of our countries. We're using, in majority of cases, TBRI for ultra, expert, but this is good. But in this algorithm, we have a line that came up, which was not included last year. And it's important information about thiominazide. It's important to make a choice of the treatment schemes. So if it is monominazide, it is treated by other schemes, and it's better to know as early as possible. And this approved technologies will help us to identify. So this is automated tests of amplification of moderate complexity. If you have lab test in your lab network, it is usually done at the level of the microscopic laboratories. Now, if we have identified the microbacteries of tuberculosis or its DNA, expanded diagnostic algorithm provides for identification of the resistance or sustainability of torhilanor, which is very important if rifampicin is sustainable, and to isoniazide to separate monoresistant tuberculosis. And phenotypical PLH is mandatory because it is the widest spectrum at the moment in relation to majority of drugs. So, if rifampicin is sensitive, we say that automated system of medium complexity will help, because at the same time we'll measure the sustainability to both drugs. But if the resistance to the rifampicin has been identified, we need to test for phthorhimanol, and expert XDR test will help us with, or our old friend method of linear probes for the second line. And we also have that if we do technical sensitivity, it's better that we do it in parallel, and within one day we can learn about resistance. What about sequencing? Where in the near future in this algorithm? Well, it's clear. Sequencing for primary diagnostics is not good. It's expensive, complex, and not realistic. But for expanded diagnostics, of course. Where it could be? First of all, this is a target or full genome sequencing. If we know that there is a resistance to rifampicin, so that we can learn the full spectrum information about other drugs. But this technology is something that we will need to detect mono or poly-resistant TB.
There's no recommendation yet. I think that this will be a burning issue in the nearest future. Thank you for your attention. Thank you. Thank you very much. I think there's been new and very useful information for laboratories. I think even during the first year, this is in the development when simultaneously they approved, so many tests were approved, and this is the first in the history, and it's becoming more interesting in the work in the laboratories. The participants, I would like to again remind you again, if you have any questions, please write in the chat box or for the Q&A session. If you have some time left at the end of the session, the presenters, please, they will respond. If not, then there will be a response provided in written in writing. Our next presenter, Malik, represents USAID project and TB in Central Asia. He is the specialist on changing the social behavior communication in Uzbekistan. He has a experience of 12 years experience of working in the healthcare system, and the past 4 years he's been working on TB. And in parallel, he's a scientist of the Scientific and Research Institute of Public Health and Organization of Healthcare. Please, Malik, I would like to also once again remind you all the presenters that we have tight time schedule. Please stick to 7, maximum 10 minutes, please. Hello, dear participants. Hello, allow me to please start my presentation. Please put up my presentation. The topic of my process is in the disciplinary approach to identifying TB experience in Uzbekistan. With support from the agency, from the USAID agency, and to TB in Uzbekistan in 2012-15, to work with the Bukhara, Kashkadar, Navoiy regions. For the first time, we've created MDK team USAID provides support to Minister of Health of the Republic of Uzbekistan in implementing TB programs and implementing more effective ways of prevention, diagnosis, and TB treatment among population, including vulnerable groups of population. Based on the previous experience on the activity of the MDK, there's been tasks in organizing the projects in the pilot regions under the USAID TB and Central Asia program. So the principal difference between of the interdisciplinary teams and groups of various types of specialists that accept patients is the close interaction of between persons that provide assistance and people who are focusing on finding a solution for the patient's problem. If we talk about the work of the MDK, this is the innovative work in this disciplinary team among the vulnerable groups of population. Outreach personnel and physicians, doctors work with the vulnerable people from the vulnerable groups that don't know how to get high quality services and timely medical assistance. So this team does awareness work and facilitates understanding and making decision to get diagnosis and full treatment against TB. The main team is the prevention, improving the TB identification among the vulnerable population, integrated assistance to patients, and adherence to treatment, development of self-sufficiency of patients, and psychosociological support to patients. So again, if we talk about in more details about this interdisciplinary team, as you can see here, we're talking about the cohesiveness. Success depends on the success of the team. And here we're talking about socially adapted and emotionally balanced, believing in the healthcare, a person believing in the. So this team is organized as an independent expert from various disciplines, which are guided by separate development plan and certain tasks in patient-centered assistance and for high-quality medical and psychosocial supports for the patients. As you can see here from this map, here we have under this USAID project in Central Asia together with the Salman Awad Uchun, we've conducted preparation and training of the MDK teams in 3 pilot regions, and further coordination of this team is done under this project together with the Salman Awad Uchun. As you can, we have Jazak city in Fergana city Fergana, and Sirdarya is Gulistan city of Gulistan. We have teams working actively in these regions. On the target groups of the program, we have close contacts with people affected by TB, labor migrants, and people with live with the HIV PLIF. Outreach and referral. Here we can talk a lot about it, but this outreach is mainly information awareness, mini sessions and consultations on the TB issues and conducting screenings. So providing a provision of information by medical providers and social providers, support by the medical team, work with the members of the family and other clients, and involving the clients into the program, including in the social support programs, and keeping documentation. Approaches of the program on the access to TB services. First off, this is here we have social support. The next is psychosocial support, adherence to treatment regimes, and communications with the clients with the various specialists. During the screening, we do speak with the client, interview the client, and if necessary, and if a patient has certain complaints, then patient is given a voucher. So this is a referral system. So this the system approved. This referral system approved by the Minister MOH order from March 2015. As you can see here from this, the different stages of the work of the team. So we have TB services here. First, primary healthcare Mahala to work with the target groups. During these screening sessions, when detecting certain symptoms, the patient is given a voucher and is supported by at PHC or TB services to conduct TB diagnostics. After this diagnostics, if TB is identified, the patient is then starts treatment, and physiologist starts working with them, psychologist and social worker as well, and the patient is will be supported throughout his treatment. On social support, so the main activity here is again information awareness raising on TB, and so we're talking mini sessions, consultations, also psychological support, assessment of the way of life and requirements to come up with a plan of social support, referral to medical providers and social providers, and work with the family members, clients to ensure support. And again, so documentation is a must. If we talk about the different stages of the social support, then the patient so signs agreement and is then will then be supported after this. The interdisciplinary team starts assessing the situation, and then they develop individual plans, which plan work by each specialist, psychologist, physiologist. So the entire process, the entire treatment process, the patient gets support throughout his treatment process. So the patient gets necessary assistance, necessary consultations, and several times the patient is given, the patient controls through if all kinds of support, even including visits to family of the patient. In the future, there's a coordination of services and control of the quality of the services, and if necessary, if there's some problems or issues arising, there is a correction of the plan of social support together with all the entire team and the entire interdisciplinary team, and the patient then comes out of graduate from the program if he is cured and if he's completed the treatment, or if she wants, if they want to come out of the team on the social support team, if he wants to graduate from the team. So the results of the outreach, this team in our 3 projects, Fergana, Gulistan, over the past 4 months. This is a very short period of time. They've shown 2,491 screening cases. Of them, diagnosed were 746 people, and 19 people were identified. And altogether, the total number is 3,148 mini sessions on informing about the TB among population. Also on social support here, as you can see on the table, there's a number of people taken for the adult accepted for social support, 30 people for the DR, TB, and 8 people are to MDR. So the total number of patients that are under social psychological support in this case is 38. If we talk about the work on outreach activity, I want to again mention that this outreach activity is a very unique activity which allows each to visit every family and conduct necessary mini sessions, explain what they have to do, conduct awareness campaign, explain about TB. This is a whole range of activities done by the social workers, by medical providers, as well as volunteers. Also, the outreach involves consultations, preventive activity, both in medical and social institutions. We're also planning for the third year to expand our outreach, involve more districts. In addition to Jizak, we want to add Sharaf Rashidov and Galaral district in Fergana region. In addition to Margilan city, in addition to Fergana, we want to add Rishtan and Margilan, and in Sardar region, in addition to Gulistan, we want to add Sardaba and Bayawut districts. I'm finalizing, wrapping up my presentation, and if you have any questions, I will be happy to answer them. Thank you very much. Thank you. It was really interesting experience, not only for Uzbekistan, but even for neighboring countries, and I hope that this will be adopted by other countries. Since we have very restricted time, I don't think any questions we can submit them in writing, and I want to present the next presenter, Rafiz Ahmatullin. He's a laboratory specialist of the USAID project to end TB in Central Asia and in Uzbekistan. In the past, he worked as a head of the bacteriological laboratory of the Republican Center of Phthisiology and Pulmonology of the Republic of Kazakhstan. He has experience of also working in the FMS as a lab supervisor. So more than 10 years of experience. And presentation is improvement of the access to diagnostics by improving the transportation in the regions of Uzbekistan. Please, you have the floor. Hello, dear colleagues. I'm glad to welcome you all here, all our participants, and let's start our next topic of today's conference. So this is improving the access to diagnosis by improving transportation of the samples. Rafiz Ahmatullin, dear technicians, I can't switch to the next slide. Please help me out. Okay, thank you. USAID project to end TB in Central Asia and in the Republic of Uzbekistan. We have optimized logistical network. We've covered 3 regions. These are our pilot regions: Fergana, Sirdarya, and Jizak, as you can see here from the screen. Transportation of this samples in accordance with the standards of the material under research has been problematic in various regions of Uzbekistan. They have different schemes and protocols for transportation. As we know, stable and normal functioning, and there's only transportation in Tashkent only operate in the Republic of Kazakhstan and in Bukhara region. They have a good transportation system for these purposes. Logistical systems is the basis of the right so timely transportation of samples helps with the quality of treatment. It helps with the decision making and treatment, and also this is something that's used as a basic indicator of the activity of the laboratory. So the time of turnover could also be used as a benchmark to improve the entire system. So step-by-step activity of achieving the optimization plan in the logistical network was done There was a tentative assessment of the logistics conducted. Number 2, there was a data collected of the laboratory locations in particular. So these were GPS coordinates were taken by the laboratories. The third, so the development of routes. Number 4 is budget, and 5th in the finalization process. As an example, on this picture, you see our pilot region, which is Fergana. For initial assessment of the transport and logistical network, it was necessary to mark all these points of bacteriological samples. On this picture, you see 4 laboratories that with analyzers, gene expert analyzers, also 4 laboratories. So we're planning to install more gene experts and 11 microscopic laboratories. Microscopy of the USAID project worked with the national partners on developing a roadmap that shows the main bacteriological laboratories and sputum sample locations. The roadmap developers, they used software to ensure optimal routes between the polyclinics and laboratories, including laboratories with technologies of molecular diagnostics of gene experts. All routes were developed using the software and route information. When developing the routes, we consulted with the heads of the local anti-TB laboratories and experts of the project to determine whether or not the routes are good. Some routes have been corrected to prevent the movement along the way where you cannot actually move along, that have some difficulties. There's also necessity to research developing the routes using the current geographical maps. As you can see again, using the Fergana. These are the routes where the project provided optimal route for transporting the twice a week for transporting sputum samples. After the consultations with the heads of the regional physiology and pulmonology in 3 regions organized under the USAID project, along this route, starting from 26th of April 2021, Sirdarya region introduced a system of transporting diagnostic samples using regional physiology vehicle. You see the comparative analysis that would take in 3 periods. At the very bottom, we have from the start of launch of this system, and and above we have the 4th quarter and first quarter. As you can see the numbers here. For example, in the 2020, 4th quarter of 2020, there was only 581 samples collected, and 446 of them were for diagnostics purposes, and 47 of them with positive results, and 5 of them are the MDR TB. And the first quarter, again, during the period when there was a system of transportation introduced, 1,028 were collected, 921 of them were for diagnostics purposes, 64 of them were for samples were positive. But again, this is in principle, in percentage terms, there is no difference. But as you can see, the number of the number has increased by 3 times of the sustainable samples. The regular timely transportation of sputum will allow the healthcare system to improve the detection of the TB cases, in particular of the DR TBs, and timely start treatment, treating patients. Thank you. I'm done with this. Thank you very much, dear Birafis. I think this is one of our newest approaches to optimize the laboratory transportation system. We are using GPS coordinators, and I think that this is will not only improve the sputum sampling, but also the quality and quantity has improved of the. And also this positively impacted the beginning of treatment. I would like to give the next floor to our esteemed Paul from European Coalition on TB to continue moderating this session. Please, Paul.
Thank you very much, Maka. That's already been a very interesting session. It's a special pleasure for me, given my interest in community engagement, to introduce the next speaker, Mirova Dilaram, who is the Deputy Director of the Red Crescent Society in Tajikistan, to tell us more about the role of civil society organizations in TB control. And we know already we in TB Europe Coalition are well aware that in Tajikistan they have one of the best arrangements and good track record in the engagement of civil society. And so if I can hand over to you, Mirova, that would be great.
Добрый день, дорогие коллеги, уважаемые партнеры.
Hello, dear colleagues, dear partners. Allow me introducing you the implementation of the USAID project on TB eradication in Central Asia. Present you a good experience of Tajikistan on involvement of the local community in the detection work. The goal is to reduce the burden of the TB in Central Asia by strengthening the local and regional capacity for better treatment of the drug-resistant TB. The goals of the project is to increase the quantity of the identified cases of TB, improve the indicator of the successful treatment, creation of the favorable environment, and improve the financial sustainability of the programs. The beneficiaries of the projects are persons who are in close contact with TB patients, labor migrants, and HIV infected. The project covers SOCT region, 8 pilot districts. In the Sounds, we have 4 pilot districts, 2 Republican districts, and Dushanbe city. Here you can see the cascade of the continuous medical aid to TB patients, which includes patronage, psychological support provided through mobilizing and involvement of the communities. And what is specific is that from the time of screening until testing, community is involved up to the completion of the treatment course and cure. I would like to mention that the project has developed medical guidance, the model for involvement of the civil society and communities, and which is specific in this guideline. We have described step-by-step activity starting from the assessment, familiarization meetings with the partners at the local and high levels. And informational meetings with the partners in the pilot areas and signing of the agreements, both at the local, high, and regional levels. According to this guideline and the model, the main focus is made on training of volunteers, because volunteers are elected among the community. And highly organized trainings are organized to detect, psychosocially consult, and reduce stigma. And what's important is that volunteers recently had the training on electronic detection system, and currently our volunteers gradually will move from paperwork to electronic system, which will improve the work and create the quality. I would like to emphasize that in this slide, infographics, you can see the entire work on the detection, work with community, and areas of work. And again, this involvement of the community, enlightenment, work with the key groups like people in contact, migrants, people living with HIV, and of course this is the referral. And once TB symptoms are identified, they are sent to TB centers for testing. Currently, we have 5,204 tested. And of course, this work resulted in identification and the referral. 272 and 24 are drug-resistant tuberculosis. I would like to mention that the project conducts special attention to the commitment and social support. Volunteers provide assistance in treatment of the pilot areas. More than 950 food sets have been handed over to 200 LTB patients. And I should mention that the Tajikistan Red Crescent attracts a lot of support and its own resources to provide additional packages of food help. In one of the districts, twice a week, 4 patients received 4 loaves of bread, hygiene sets, by involving sponsors and corporate sector. We have also provided sewing machines to 21 TB patients, and during the period of COVID-19 crisis, when they were limited remittances coming from the migrant workers, we provided this to TB patients to help them to develop small private business, and that helped them to improve their economic status in the family. Another thing is that we're involving partners, and we transfer TB patients money that they can use to solve their social problems. What's important? Volunteers working in the communities, by conducting very close dialogue with the society, with their key group, they also identify gender violence. And some aspects of this gender violence have been resolved at the level of community with the help of the volunteers, because some of our volunteers are leaders of mahalla, jamaats, and very highly reputable people. But those which were not resolved, they were referred to the crisis centers where professional legal assistance has been provided. This work has also actively involved religious leaders who help a lot in the work with social mobilization. And it's really important because 99% of the population is religious, and everyone listens to the views of mullah in their community. The project made a focus on the reduction of stigma and elimination of gender barriers. Different trainings organized for civil society to reduce stigma and discrimination, elimination of the gender barriers, gender differentiated approaches have been integrated into the work in order to detect and prevent TB. The project implements such activities as sanitation, education, gender equality in detection, and ensuring the loyalty to treatment, creation of the patient support groups, support of families, and social support, because TB patients share their experience and stories, and that helps a lot to increase the commitment and loyalty of TB patients during treatment. And of course, we have created video film about the life and fight of people who suffered tuberculosis, who are the survivors, and who work now within the project, and experts when they visit people, and they have been considered as heroes. I also like to mention that promotion and advocacy work is conducted not only at the level of community, but the project conducts it beyond the scale. So we provide awareness activities within the main group of population. Again, we involve the religious leaders, women's committee, local self-governance bodies, and mainly we focus on youth because they're very good advocates in resolving and making very interesting decisions. We also use social networks, Facebook, Twitter, Instagrams. We have our own website and Facebook page. We also disseminate this information through media networks, social networks. And I would like to say that our traffic police is also involved in the work of the project to disseminate information. We organized charity concerts, and the funds will then be used to support families for TB patients. And We organize national holidays, which is a very big platform to disseminate information. We organize world campaigns, and we actively work among children at school. And school children are very good disseminators of information and envoys of health in their schools, and they inform their parents very well. And every parent listens to their children's views. And I would like to mention about the activities that have been conducted during pandemic. Tajikistan has been also affected by pandemic, and during this period of COVID-19, volunteers, of course, by taking measures of self-protection, actively mobilize their forces even during voluntary self-isolation and distribute information while visiting households, taking count the physical distances and other COVID-19 precaution measures. They even used state traffic police to conduct the information campaigns, and people were asking questions from their balconies in the apartment buildings and getting the answers from our volunteers through the loudspeakers, because there was a big panic among the patients with TB and other infectious diseases. And in some districts, volunteers started even helping medical institutions like TB centers and became a bridge between community and TB center by providing foodstuff, delivering it home, and even providing pills and drugs. I need to also talk about the high-level work of TB centers and healthy lifestyle centers and HIV centers. During pandemic, our volunteers, together with them, also disseminated needed information about pandemic. And on this slide, you can see the audience. Some work has been done at the level of community with individual contacts and interviews. It is important to mention that this involvement of community work has been achieved and recognized at the international level. And this experience and achievement will be voiced in the International Conference on TB. And our article has been approved, and we have created this stem. And I can say that the activities on identification of the TB cases with participation of community became not only efficient, but also sustainable during pandemic. From April 2020 till April 2021, in 8 districts of soaked region, the identification rate increased to another 18%. We would like to praise our partners, local authorities, women's committees, regional health offices. Migration service became very good helpers of the project. They provide systematic information about the migrants who return, who timely get tested, screened, and receive information. Mahala is very active, including religious leaders. Civil society and community are very much interested, and that makes our sustainability component very strong when community itself is concerned about the health and takes efforts. And we should also talk about the local business people. We very actively work in involving them in order to reduce the financial burden of the families. And during the implementation of the project, many organizations got interested with the USAID project. For instance, UN Women requested us to involve our volunteers to work with women who are exposed to physical violence. And this is the work that we have conducted. And 6 centers will be referring women who were exposed to physical violence, and crisis centers continued working with them. And the next slide shows the work again of volunteers who take hard time, even riding donkeys to reach remote villages and perform the work and control the treatment of TB patients. Thank you very much for your attention. If you have any questions, I would be happy to take them. Thank you.
Thank you very much, Mirava. That was very helpful. I think that you showed a good example of how many activities can be brought together in a coordinated way, achieving sustainability. I'd like now to move rapidly to the next speaker, Reshma Suresh, who has wide experience in the private sector in the development of IT tools for health services, and has particularly worked on artificial intelligence for tuberculosis case detection. Sorry, I'm getting a lot of interruption here. I'm sorry, I'm not sure what's happening. There's a lot of conversation there. No. Okay. If I can turn to Reshma Suresh, and looking forward very much to telling us how artificial intelligence can create meaningful outcomes for TB detection work. Reshma, over to you.
Thank you, Paul and Makka, for moderating the session. Hi, everyone. My name is Reshma Suresh. Please allow me 1 minute to just get the presentation up. I hope you can see my screen.
Yes, we can.
Hi, is my screen visible?
Yes, no, we can see the screen well, Reshma.
Okay, great. Thank you very much. Hi, everyone. My name is Reshma Suresh. I head business operations at Cure.ai. At Cure, we build artificial intelligence, specifically deep learning-based technologies that can help in radiology diagnostics and also disease management solutions. We started in 2016 with a vision to use AI and deep learning. Deep learning is a much more robust form of artificial intelligence to improve patient outcomes. So we had the idea that why can't we use AI to teach machines, that is softwares, to read CT scans, X-rays, MRIs, etc., that at the same level of accuracy as a human reader, just like how they do it, so that this can be extended to populations which do not have access to quality healthcare. So that's how we started in 2016. As on today, we are live in about 49 different countries in 425 sites across different geographies and disease areas that we work in. To talk a little bit more about Cure and how we started, so we have two flagship products. One is for head CT scans, which can identify different anomalies, different pathologies, and especially critical care cases, and let the physician know which one needs to be reported first. Now, this could include bleeds, fractures, midline shift, etc. The other flagship product that we have is for chest X-rays. Since 2016 that we've been working on and very actively in the field is for chest X-rays. What it does is that it can identify different pathologies and anomalies in a chest. What it does is it classifies an incoming chest X-ray as normal and abnormal. If it is an abnormal X-ray, it further looks into different findings that it can identify. For example, if there is a nodule, if there is a consolidation, opacity, etc. And all of this, this constitute about 29 different findings, which covers across different disease areas like tuberculosis, COVID-19, lung cancer, COPD, congestive heart failure, and so on. Initially, when we were working with different key opinion leaders, hospitals, teleradiology segments across the world, we thought that we will use AI to generally improve the accuracy in reporting, reduce the turnaround time. Now, the AI can actually, the software can actually report or generate reports within minutes. So within 1 minute, you will have the entire report that is generated. But while we were investing more time in working some of the rural parts of India, speaking to different health secretaries, national TB programs, we realized that there are many countries and large pockets who do not even have access to basic healthcare diagnostics. So we thought, while we are having a large focus in the developed markets, working with hospitals, looking at improving the workflow, we could also take these technologies to the rural part of different rural parts of the world and improve patient outcomes. So while we were researching more about that, tuberculosis was one key area which we were very passionate about, where we wanted to make a difference. Since then, we started working on this. So what the software, out of all of these 29 different findings, one of the findings that the software can identify is tuberculosis, apart from the other lung health diseases. It can, so currently it can also prioritize in a work list for all the X-rays that could have an indication of TB. It can also monitor the disease progression for TB. So if I were to show how the software really works, is that the moment you acquire an X-ray in a primary health center, or in a mobile van, or in a hospital, in a provincial hospital, or any healthcare setting, the moment an X-ray is taken, the software captures that automatically. It processes using different AI techniques and creates a report, what you are seeing here, automatically in matter of under a minute. So what you can see on the right-hand side is the different findings that the software can identify, with a definite answer whether this finding is there or not. On the other side, you will see these contours or overlay, which marks out the abnormal area for a physician to have an immediate attention to look at it and report accurately. As I mentioned before, it can also look at disease progression monitoring for TB as well. So the product, what we call QXR, currently we work with many programs. We work with different multilaterals, prestigious institutions like Stop TB Partnership, PATH, FHI 360, many other organizations across different parts of the world. But ever since we started developing our algorithms, we've been cognizant of the fact that these are medical device softwares. It requires a lot of external validation. So at a very early stage, we started engaging. This is much before we deployed our products in the field. We started engaging with institutions such as McGill, MGH, Mayo Clinic, who have actually validated our algorithm and published papers in peer-reviewed journals. As of now, we have 7 US patents and about 35 and more presentations and peer-reviewed publications that we have. Out of which, one thing that we would like to highlight is about the research study that was conducted by Stop TB Partnership and FIND, where they evaluated different AI and CAD algorithms that are across the world. Out of this, they found the accuracies of QXR, the Cure AI software, to be more performing than the rest of the AI and CAD software, and also which is very much in line with the human reader when using GeneXpert as the ground truth. This became the basis of the WHO recommendations. So the WHO released the World TB Day this year, March 24, 2021. WHO released a new guideline for using AI and CAD algorithms as an alternative to human reader. And Cure AI QXR was one among the 3 different softwares that has been identified. So with all of this, we started working with programs, different programs, NTPs, directly with MOH for large immigration screening in different countries like Malaysia. The software is also used for immigration screening, country-wide immigration screening for TB in Australia, in Malaysia, in UAE, etc. And the other, further when we looked at it, what we understood is that while there are machines which can acquire X-rays and the software can process it, we went a step further to understand how this can be integrated with handheld X-ray machines. So earlier this year, we actually announced a partnership with Fujifilm by integrating Cure software in Fujifilm's handheld Exire machines. This has been also live and deployed in many sites that we have across India and different other parts as well. So the first program, in fact, that we started working apart from India, some of the Indian setting was in Philippines with Philippine Business for Social Progress. After thorough validation, different understanding with our partners in Philippines, we realized that for a TB program, while X-ray and X-ray AI is one component of it, there are several other activities that a program does for identifying a case successfully. And the treatment initiation and so on. Now, these are different decentralized processes. It could include registering an individual, looking at their symptoms, risk factors, the X-ray acquisition in itself, giving this X-ray to a physician for final confirmatory test, uploading an expert or a TrueNat test, a bacteriological confirmatory test, and assessing all of this, right? So we thought, why can't we look at a step further and kind of get all of these decentralized processes in a single platform. So we developed a product called QTrack, which is part of our workflow management portfolio. What it does is that it tracks the journey of a patient from when they are enrolled to treatment completion. So it has a mini EMR, which takes all of these different parameters into consideration, like signs and symptoms, risk groups, etc. It automatically generates the AI results. It gives a complete dashboard and analytics for the program managers to get an overview of the complete activity that is happening on the ground. The software, the QTrack software, is in conjunction with the AI for X-ray software, is used by the frontline healthcare workers, the physicians for reviewing the report, and also by the program managers to assess the complete activity. Now, the next problem at hand that we had was two problems, actually. One was that now we've cracked digital X-ray machine, but there are several other areas where you do not have a digital X-ray machine. They still run on conventional analog X-ray machines. What we did is that with the QTrack application, using a smartphone, you can simply capture the image of a conventional or of an X-ray film and get the results instantaneously on the phone. So this is also used by several programs, especially some of our programs like PATH in Myanmar and some of the other countries. So that is what constitutes the complete QTrack. We also have a feature which uses a chatbot. This we actually developed during the COVID-19 outbreak that can engage with the patients. So it engages by asking specific questions, understand the response of the patients. There is a backend AI algorithm that can understand what the responses are and interpret it and provides meaningful information. This can be used for active case finding for tuberculosis, like for example, screening of a household contact and monitoring the progress of their symptoms. Can be also used for the first step for medical adherence. So it's a complete remote patient management software. It is being used by the MOH, Ministry of Health in Oman, for the countrywide COVID-19 isolation monitoring and several other home healthcare solutions as of now. This is a workflow on how would you use successfully an artificial intelligence software in the screening setting. So you could either have a mobile van or a hospital. The individuals, the cases walk in, they could have signs and symptoms or they're from different risk groups for either passive case finding or active case finding. You get an X-ray. By the time the individual gets an X-ray and is out of the X-ray room, the software knows exactly which individuals need to be collected. The healthcare workers knows from the software that which are the individuals who need to have a sputum collected immediately. So the software segregates all the normal, looks at all the abnormals, and looks at those cases which has signs of TB. You take a sputum and then run it in a CBNAT through a CBNAT test. And you have the treatment initiation done on the same day or maximum in the next 2 days. So this is a workflow that we have seen working with different programs, be it in Philippines, in Myanmar, in India, in multiple Bangladesh, Indonesia, everywhere, in Africa, everywhere what we have seen so far. Combining our different software, it can also give alerts for the healthcare workers or the physicians using the QTrack mobile application. If you have a physician, the physician can in real time see what the X-ray is and what the results are using the application. So that's what the entire workflow would look like. in the entire TB care cascade with the 3 different products that we have, QXR for chest X-ray, QTrack for the complete workflow management, and QScout for engaging with the individuals using chatbots. We can tackle all these gaps and reduce these gaps in the care cascade significantly. I'll move on to the next slide. So what is beyond tuberculosis? What is that we can do? Like I mentioned, QXR can not just identify about TB, but several other lung diseases as well. Can we make our existing TB screening framework compatible for screening all the other lung diseases? So the thought that we have is that when an individual walks in, if you look at the case of, say, lung cancer, many symptoms and risk factors overlap with TB as well. So can they, while they walk in and then they get a screening done, can you look at all the different other findings or all the different other ailments that a patient could potentially have, or the presumptive case could potentially have, say TB or nodules in the lung that could be suggestive of lung cancer, having a cardiomegaly and pleural effusion, which could be suggestive of heart failure, COPD, or even COVID-19, both symptomatic as well as asymptomatic. This is a general workflow that we thought that could be used for a comprehensive lung health screening. So this will be a parallel workflow to the existing TB screening in itself, because those who are having a sign of TB could also have other abnormalities, or say a sign of cancer or COPD or CHF, congestive heart failure. So this is what we were thinking we would put together, a general concept on how we could have a complete lung health screening, one-stop screening process. Quickly, this is the last part of my presentation. I would like to, first of all, we would like to thank all our partners who've been working with us in supporting this and creating the story for using artificial intelligence and making that case, which actually led to put together everything that led to the WHO endorsement. It really helped, made a difference in programs. PATH is one such program who has been early adopters of AI since 2019 that they have been using it. This was demonstrated in a PPIA model, the private sector engagement model, in a semi-urban city in Nagpur in India, in Maharashtra, where there were vouchers that were handed over to individuals who were coming to see an informal provider and who were exhibiting some symptoms. Now, the results, this project has been successfully completed. The results of the project shows that there has been about 20% increase in the overall case notification in comparison with the previous year. Out of this 20% overall case notification, 13% of such cases were attributed to use of the AI software. That is, these 13% of cases would have been missed if the AI software was not present or if QXR was not present. We could also see that 50% improvement in the microbiological confirmatory test as well, and under 10 minutes for registration to get the sputum and then get the registration and submission. This is in fact the first ever deployment that we have done in one of the district hospitals where you have a large migrant population as well in India. Again, a large difference in cases that are detected from previous year. Here we also would change the protocol in which how a TB patient would go through. Initially, it was take an X-ray, come to the X-ray room, go to the go back to your OPD physician, then come back and go and submit your sputum. In this whole journey, what used to happen is that the patient either do not come back, or it would be somebody else who would be coming and collecting the X-ray report on behalf of the patient, or or they don't turn up at all, or by that time you would have lost those particular individual. We changed the protocol to make it much quicker. Any X-ray that has been identified with a potential TB is sent to the TB sender, where a chest physician looks at it and the sputum will be collected immediately. This was one of the reasons why we could see a huge increase in additional cases, and how a huge turnaround time difference, improvement in turnaround time, not just in diagnosis, but also treatment initiation and completion. Philippine Business for Social Progress in Philippines, they have mobile vans which goes to different communities. Here also we have seen a lot of difference. Here the turnaround time that they had was about 3 weeks, which we dramatically reduced to 2 minutes or 3 minutes to understand from the X-ray what could be the next steps. We also had an opportunity to work with London School of Hygiene and Tropical Medicine in Malawi. This is with Dr. Elizabeth Corbett and her team. Part of SCALE project, high HIV prevalent population, 72 clusters of high HIV prevalent population where the software was used. This was another interesting problem that we solved. Initially, we were looking at X-rays, digital X-rays, where there is an internet facility which can process the X-rays and give the results. But this, with this project, what we made the difference is that you can not just use the software on cloud, but the software can also be used to process in areas which are remote without any internet connectivity and have data privacy restrictions, can use a hardware which we provide. It's a small hardware and process everything completely on premise or completely without any internet connectivity. This is yet another program we are working in Myanmar with Myanmar Medical Association across 7 different sites. Similar to this is also with PATH as a part of TB Reach program. Put together, we have multiple programs that we've been running that are USAID funded, USAID funded projects in Vietnam, that is with FHI 360 Vietnam, also in Philippines, FHI 360 Philippines, TB Reach funded programs in different parts. One such example is what has been shown in this slide as well, a complete surveillance model where anybody who is coming to a hospital to take an X-ray. This is in partnership with the government, local government here in Mumbai, India. Anybody who's taking an X-ray, the software would look at if there are any symptoms. Now, this could be pre-operative, post-operative, any X-ray that comes in, and they will be subjected to a further examination, or they go into the loop by the TB officers. They will look at the management of those patients to see whether they are diagnosed or they will be diagnosed with TB or not. That is the end of the presentation. Happy to answer any questions that you may have.
Thank you very much, Reshma. That was fascinating. I particularly enjoyed the reference you made to tying up with Fujifilm and the use of your technology with handheld X-ray machines, because in terms of outreach into communities, we've been aware that this new technology of handheld tools is really a game changer that can be of great benefit. But I must now move on to the last speaker in this session. But before doing so, can I remind you that we do have a question and answer session after the last speaker, but question and answers to all of the 6 speakers in this session. If you wish to ask a question, please use the Q&A tab that you have on your screen. Lastly, for me, it is a very great pleasure to introduce the next speaker, Tatiana Nikitina, whom I've worked with for several years now, and has been, is a founder and lead worker of Intilish, which is one of the major civil society organizations in Uzbekistan, and who's going to tell us about the particular USAID project that she now leads. Tatiana, it's a real pleasure to have you and to interact with you again. Welcome, and over to you to speak now.
I can hear her. Thank you very much. Can anyone hear me now? Yes. Again, good evening, dear participants of the conference, dear colleagues, friends. I'm pleased to hear you all. It's been a long time because of the COVID pandemic, but nevertheless, I welcome everyone. The conference is being conducted in Uzbekistan. Hopefully, we'll see each other face to face in Uzbekistan. Our program, my presentation is called NGO Reels Intilish and TB in Uzbekistan. This is the USAID project. I will tell you to start off in order to make you why we're implementing this very project in Uzbekistan. This is the mission of our organization. On this slide, you can see on the right side the team that implements this USAID project. On the left side, this is the coordination meeting before the start of this launch of this project again. So the mission of our organization is to improve the quality of the life of the population, vulnerable groups of population by maintaining the health, raising the cultural awareness and social adaptation. This NGO RIAS Intellige, this organization, our organization is the first recipient in Uzbekistan of the US TB Loan Award, and it was mentioned several times today. It's a new program by USAID, accelerated project, and this is one of the components is TB Loan. It's a local organization network, and this project we won this project in Uzbekistan. So the launch of our project was during the quarantine 2019 lockdown, but nevertheless we continued working. We started working with a huge enthusiasm. This was on the start on the 23rd of March 2020, the end of this project. So we're planning to end this on the 22nd of June in 2023. And budget of our project is, as you can see on the screen, is almost $1 million. So objectives, let's talk about objectives and tasks of our projects. So the purpose is
to expand the diagnostics and treatment of TB for vulnerable groups. Vulnerable groups are persons who got released from the penitentiary institutions, migrants, injection drug users, parents and their kids. And during the implementation of this project, this included group with limited access to medical services. The first task of our project is to ensure the access so it was for up to 500 representatives of the vulnerable groups. Here we used such approach as outreach and NTK. And the second task was to ensure the services of psychosocial support to 200 kids which get anti-TB treatment here in Tashkent. We implemented through the NGO and create the conditions for further development coordination of the representatives of National Partner Network. We're planning to create a national network on improvement of legislation in Uzbekistan and create and develop guidelines on social psychosupport in Uzbekistan. Number 4 is ensuring information support. For instance, development of the video film, and we're also publishing booklets. The presentation is related to the multi-sectoral approach to the implementation of our project, so I would like to present you the institutions with whom we implement our project. First of all, it's the Ministry of Education, Ministry of Health of Uzbekistan, National TB Program. It's probation service, social education centers, rehabilitation centers under the Ministry of Interior. Probation service is under the Ministry of Interior, which has been organized in Uzbekistan recently in 2019 and covers the work with people who get alternative ways of punishment and people who got released from penitentiary institutions. Social adaptation centers, these are centers under the regional Hakimiats of Tashkent city that provide services to all people who are released from prisons. With them, we have long-term cooperation established, and the rehabilitation center under the police. This is a center where we have people who do not have the shelter. Next agencies that we work with very efficiently, it's a ministry to support Mahala and family. This became a government institution, a ministry. Other medical institutions, including AIDS service and higher medical commission. So we have very long-standing and fruitful work with AIDS service throughout the country. Tashkent city authorities both district and city. Then the centers for retraining of the unemployed under the Hakimiyat or the local administration, because people who are looking for jobs and are our clients, they can also go and get trained in the service. And Mahala committees. This is a wonderful structure, Mahala committees, with whom we can solve basically all issues. This is a map that shows where those TB institutions are located, with whom we cooperate. Here you can see Republican Scientific Practical Center, Tashkent City Center of Pediatry and Pulmonology, and 5 district anti-TB dispensaries. At the Republican Specialized Scientific Practical Center and Tashkent Center on Pediatry and Pulmonology, under the project, we have equipped the rooms for psychosocial support from 9 till 6 in the evening, 6 times a week. We have a social worker, psychologist, and lawyer providing services. So in the institution for children, we consult children by psychologists, and social workers consult parents, and psychologists also consult parents of kids who are on stationary and out-of-patient treatment. Partner organizations. So what are the functional mission of this institution? A national tuberculosis program. This is diagnostics, treatment, psychosocial support, methodological work. And taking the opportunity, I would like to thank the head of the national TB program, Parpiva Nargiza, her entire team for support and understanding of the innovational approaches in resolving TB issues, and organization of the civil sector and its involvement in TB challenges resolvement. Social adaptation centers, rehabilitation centers under the Ministry of Interior. They help to involve our target group. We also have institutions which control our activity. So we have a committee that includes officers of probation services and others. So we have planned activities with them. When we bring together representatives and those who got released from the prisons and who are taking alternative punishment measures. Retraining center. This is a center related to the Hakimiyat of Tashkent, and it's important for us because people who, due to certain reasons, cannot come to work, they can get professional training on 18 professions. We cooperate with the center since 2015, and the trainers for so many years have the empathy and have tolerant attitude towards our target group, and our guys attend courses with great pleasure. And those people who go through the professional training, they also get the transport pass so that they can daily attend those courses. A ministry to support Mahalla and family and Mahalla committees. This is, of course, involvement of the target group, informing the target group. And again, we create the schedule coordinated with the Tashkent City Hakimiyat Ministry to support Mahalla and family, organize sessions, interviews, information, discussions with the population in Mahallas. We tell them where we are, what we do, and where you can address if you have any symptoms of tuberculosis. And this work is getting progressed very well, and the ministry is responding to all our requests very efficiently. Other medical institutions like AIDS service, they help to get the test done, get the disability status, and get certificates. On the picture to the left, you can see some of the information campaigns at Mahalla. To the right, this is a meeting in our office with people who released from prisons. This is the head of the probation service of Uzbekistan, Colonel Ismailov. He visits our office quite often. And at the very bottom, we celebrated the Day of Combating TB at the Tashkent City Center of Pulmonology. And we have granted some gifts under the project, and there are some placards so that the children made themselves. And kids received the gifts. We invited animators. You will see those pictures as well. Here you can see the MOU that we have signed with Ministry of Health, so that our relations are based on the social partnership. So, it's between Ministry of Health, National TB Program, and the MOU with the National TB Program. We attached additional agreement for each project which is implemented by us, because we implemented different several projects in TB. This is the MOU with the probation service. So what kind of services we provide under our project? So these are social services for the children and their parents. And this is one of the complex areas that the civil society could help with. This is assessment of social profile and needs of kids and their parents, assessment of vulnerability to TB, symptoms of TB, referral to specialist, transportation for testing, assistance to control psychological status, expanded legal services, and school of patients. I will not take too much time and tell you about all activities that we perform, like the School of Patients. You can see how we do it, how all happens. Once again, I would like to tell you about services like the social services. These are individual informing on TB, screening and survey on TB, assessment of needs for social assistance, consultation, development of the individual plan, psychosocial case management, transportation assistance to get tested on TB, and professional courses for TB clients. And we have group services as well, consultancy, legal services, and information. So we inform on TB, consultations, involvement of School of Patients, training in the school, conducting webinars and information sessions for Mahalla reps. Legal services. So what is included? So what kind of services are mostly provided? This is restoration of the lost documents, help in obtaining documents, this heritage, subsidies, getting pension, disability status. We publish official letters on behalf of the clients and further send it to the government institutions. It could be Hakimiyats, prosecutor's office, Ministry of Interior, those which have the relation to certain issues that our lawyers can help with. This, you can see the School of Patients. This is the chief physician of the Center of Pulmonology of Tashkent, Nurulaeva, who is our long-standing partner in implementing our projects. And you can see our lawyers, psychologists who are providing assistance to the child and adults. So this is a School of Patients where we provide consultancy. 1st September, we have celebrated Independence Day. It was a big holiday because it's 30th anniversary. And this celebration we have depicted on this picture. And you can see the representatives of the National TB program, animators, our children who get treatment at the child section. So kids are always happy about these celebrations and holidays which are implemented by the project. These are the consultations of the psychologists in our office. And you can see kids who are very responsive to all events that our psychologists conduct, that we organize under our project. And I told you that we have opened the sections in 3 institutions, and when we installed the aquarium fish bowl there, this kid came and has been watching the fishes for half an hour straight. So this is the response of our people who respond to social and the mental support. A very thankful audience. So it was enough to just put the fishbowl for the kids to stay there for a long time. So he was so inspired, and we were all so happy and made the picture of it. So we have provided big number of services, 1,601, 687 are vulnerable, 554 are children with TB, and 370 their parents. So more than 10,000 have received services, and we helped with transportation for testing, psychosocial support, and expanded legal and art therapy in the School of Patients. I like to mention that such services transportation is very efficient as far as identification of the TB. Unfortunately, part of our clients do not have even funds to use transport to get to the institutions and get consultations. And this service helps us to transport people to get diagnosed since they might not have the opportunity and the financial status for that. Thank you. And I would like to say that under the project in Tashkent City, thanks to the project, we have identified 41 people with TB and 10 of them with multi-resistant TB. And we think that this is our victory and the victory of USAID in the country, who believed and assessed our capacity in the right way, so that we got this grant assistance or implementing this project. Thank you very much. I would like to thank organizers for this opportunity to take the floor. Thank you. If you have any questions, I would be happy to take them.
Thank you very much, Tatiana. That was a wonderful summary of what is clearly a very ambitious and wide-ranging program of various social and psychological inputs to TB care in Uzbekistan. It was very helpful to hear all that. We now move, we have, I think, I'm assuming that we can carry through until about 20 past 4, in other words, for the program. So we have about 10 minutes left for questions. I don't see any at the moment on the Q&A. Are there any on the chat? No, there was one that's long ago been already answered. So if anybody wants to ask a question, maybe you can just click on raise hand and we can take note of you. We've had 6 pretty exciting talks, or are we all feeling a bit tired at the end of the afternoon? Any questions?
Sorry, Paul, can I have question to laboratory parts? Can I ask?
Absolutely, absolutely. Carry on.
Thanks. У меня вопрос по первой презентацию, которую предоставил Евгений.
First, regarding the first presentation given by Mr. Yevgeny this year, as was pointed out, they approved 2 more texts, the advanced to identify TB and MDR TB. Depending on the country where you look at all these 4 tests, which one of them could we select? Because when the country has no experience, when it's some sort of recommendation or advice. If you have experience on test regimen, on using these different types of text, XDR tests, and what we need to look at when the country is deciding which test to pick out of these 4 that we need to implement in our country. Thank you. This is the question for Evgeny, or it could be Vladimir too.
Evgeny, are you still? Yeah. Sorry, Evgeny, you still with us? Are you happy to respond? I wonder if Evgeny is with us. If not, perhaps Malik Utashov would like to say something. We seem to have lost our panelists, Marka.
They are tired.
Well, that's difficult, encouraging everybody to ask questions and we haven't got the people to answer. Would you like to say anything more about what's behind the question, Marka? Because I thought it was interesting. I mean, it is a...
Мой вопрос более была вот новые тесты, как...
My question was about new tests, about different types of tests, and maybe we also have the difficult complexity tests, Hein test that determines the DRTB or the XDRs or the... And WHO approved, but which of these tests could be selected for a country? Because we all have different capacities. They all have the similar functions, right? Of all these 4 tests, they are the same class. And the question was, if there's an experience of testing these, using these tests in other countries, out of these 4 different types of tests.
Does anybody else want to come in on this issue of the significance of the probable new tests for TB?
Может, я попрошу Владимиру. Я вижу Владимиру.
I see Vladimir's here with us.
Ah.
Yes, Marka, hello. Добрый день, да. I connected a bit with later. That's why. Can you please repeat your question? Yes, of course. I will repeat my question. So all these 4 new types of tests that determine the resistance, and that so they are practically have the same functions. So a similar infrastructure, similar hardware. It's almost the same. So the question is, for a country, countries, because all countries have different capabilities. How can countries pick which one to pick? You have experience of introducing this as a test pilot, right? In other countries, or maybe you haven't done this in your country yet. Or what we need to look at, what we need to be careful of when we try to. Do you want me to answer in Russian? Yes, I think because the majority is a Russian-speaking participants today. Yes, there's a document which is now, as you know, being developed with participation within the Global Laboratory Initiative, which is called Selection Guide. In other words, it's a guide for picking, for selecting, which will allow the national TB programs to select the test that's more fit for their countries, for their services, as far as the infrastructure, as far as the servicing, this hardware, as far as the availability of service engineers and support in several countries. Because as we all know, these centralized platforms, they require more complicated, more sophisticated support compared to Gene Expert, for example. And of course, we are expecting that this document will come out very soon, will be available for national TB programs. As for the experience in supranational reference laboratory and Gauting, we are planning only to introduce the system of PDMAX system in Tajikistan, in Turkmenistan. We have plans. These plans have been affected by COVID. This is very unfortunate. That's why we cannot say anything right now about the experience of introducing these systems in our countries, partner countries. But yes, we adopted it in our countries, and we tested the systems PDMAX and Abbott plus Roche. And so in other words, in Germany we have experience, but not in Central Asia, unfortunately. Only in Germany. Thank you very much. Thank you.
Thank you very much, Vladimir, for jumping in. That was helpful.
Welcome.
I'm wondering if we have no other burning questions. It's almost the time that, in my estimate, we should be finishing this session. I think we're allowed now a 10-minute break, and then we should come back for a last review session and summary before the end of the day. So unless the organizers suggest otherwise, I suggest that we go find ourselves a cup of coffee and come back into plenary session, I think, at what will be 16:30. Marka, do you want anything else to say? Anything else as we close this part?
I just want to add one organization thing. Уважаемые участники, которые участвовали.
Dear participants that have participated in the first session, if you You need to connect to the same link, link one, please, to be able to connect to the panel, to the. This is all from me. Thank you. Thank you all for a very interesting presentations of yours. Thank you.
Мои коллеги, как мы ранее уже запланировали.
Dear colleagues, as we planned earlier, now while we are working on preparing the resume on parallel sessions, now we will listen to a presentation by the head of the anti-TB national program from Kazakhstan, Mr. Aden Malik Maldabekovich, about the impact of COVID to TB fight in the Republic of Kazakhstan and Kazakhstan's experience. Please, Malik Maldabekovich. Good afternoon, dear colleagues. Apologies, first of all, because due to various reasons we were not able to provide this presentation this morning, and I will try to correct this mistake right now, if you allow me, if I'm doing everything correctly. Can you see my screen? Can you see my presentation? Yes. Okay. Please tell me how much time I got. I want to stick to the time frame. Let me know. 20 minutes is your time, sir. All right. So then, thank you then. Again, dear colleagues, I think everybody, previous presenters, previous heads from national programs, I'm sure they spoke about the COVID-19 impact to TB situation and how various services were affected by COVID. And Kazakhstan is no exception to that. And we also have challenges, and we're still. I wanted to say very briefly, talk about the TB situation. If you look at this, these are the main parameters of the incidence rate and mortality rate for the past 10 years, but impact of 2020, as you see, the incidence rate has decreased by 21.7%, where all prior to COVID maximum this was only 12%, but 5% is about average 9-10% is an annual reduction of this was a reduction, and we understand that this difference of 12.9% is lost cases, LTF use, but unfortunately this is no matter how hard we try, but we still have that. No matter how hard we try to take measures, but this is the situation. And again, the same thing with the mortality rate. If it's less than 12%, in 11.8% over the past 10 years, never decreased, and this was more than we seen in 2018 and 2019. This parameter has decreased only by 5%, and what's also interesting here, what's noteworthy, this parameter remains at the same level. So the mortality rate has stayed the same. For 6 months of the 2020 and 2021, we have a slight increase in about 1.6%, and the past 8 years. So this is only 5%. So on the one hand, we understand that we have the LTFU cases, but we don't know how many or how this will lead to the increase of the TB patients in the future. Now, the next one. Okay. As we already spoke, in order to implement the resolution of the last conference, Kazakhstan is also moving forward to ensure access to both rapid diagnostic methods. We have 128 equipment, gene expert devices. Out of majority of them are at the PHC level and during the first approach by the patients. And of course, we've changed algorithm, and now this diagnostic algorithm First we use gene experts, and after that, if gene expert is positive, then we do other tests to determine the status, whether also LPA in all the regions of Kazakhstan, in all laboratories. In some regions, LPA, there are several LPA devices, and they allow us to successfully diagnose, establish, diagnosed MDRs, DRs within 2 days, and of course, same likewise, Kazakhstan, starting from 2016, is moving forward to implement new treatment regimens using new drugs and reprofiling. Starting from 2020, practically is purchasing all drugs, all these drugs using state budget, and at the same time, in 2020, we received additional funds. Also, I wanted to say here that gene expert equipment is being serviced with there's a guarantee, but the cartridges are purchased using the state budget funds. So there's no restrictions as of today, and practically among all these ID cases, about 100% of cases, all patients are getting gene expert support. Effectiveness of treatment. This cohort has shown so DRTBs, and we see what tendency we see negative. We think that this is the COVID impact of COVID, the efficiency of treatment reduced to DR from 82% to 80.5%, and efficiency of the susceptibility dropped from 87, almost 88% in 2020, and went down to 84% in 21. We analyzed data, we analyzed this case, and we understand that during the pandemic, when the PHC facilities level institutions, they did not work officially as due to quarantine for 7 months, and of course the outpatient treatment, especially among a vulnerable population, was really complicated. And let's say if usual population, we used methods of outpatient treatment, but the key groups of vulnerable population, it was really difficult, because even those NGOs that worked with us during pandemics, they were also, especially this quarantine period, they had limited capacities. And so now what we used in order to maintain treatment of the patients, here we have to say that what helped us, that we are under the existing project, and we were moving forward towards a patient-centered approach to bring the treatment to the places of living of the patients. So there was a network of PHC. Sometimes we used day hospitals, but mostly it was mobile brigades. We used the video control treatment from the beginning of the project, and then we extended that. And as we trained and we prepared the infrastructure and we developed this experience, we increased the number of patients starting treatment from the first day one in the outpatient conditions. In 2014 was 9%. In 2021, 6 months of 21 was more than 70% of patients. And of course, in parallel, the key good thing was that today Kazakhstan has a opportunity to maintain that level, to maintain the social motivated patients, using social assistance, social support, and this support in 2020 was less than 1.7 billion Kazakh tenge, and practically this allowed us to cover more than 88% of the patients during the outpatient treatment. So these are the patients, they received support because they were taking the drugs. So over the past 6 months, this amount was more than 877 billion tenge, but we're expecting that it will remain the same level. Same volume will be the next year for the social support for sure. But at the same time, if we consider the active contingent of patients, we're hopeful that we'll be able to cover even more patients with social support and social assistance. And of course, one more factor that was interfering with our activities from our main activity is the fact that during the pandemic in 2021, all anti-TB organizations of the regions were involved in the fight against TB. So these hospitals that had patients with the COVID, and they were getting from the treatment from COVID, and 60-70%, 65% of COVID last year, and 64.8 this year. And of course, we still had some beds that we could use. We could also use in additional, and many other institutions in the country were involved in the response to COVID, infectious diseases, many other. But right now I'm talking about our service. And at the same time, in parallel, we see there's an increase of patients, number of patients with TB patients, and of course, we're pleased that in 2020. 7 people died to TB, and this year this figure is 0. But they died from the COVID infection. We need to point out that despite the fact that over the past 12 months there was a work done to respond to COVID, to prepare the infrastructure, the equipment, everything. This year during the COVID infection, it was. Decompensation happens really fast of the organism, and there's more number of deaths than compared to last year on the whole in the entire healthcare system. So in this situation, our partners, Global Fund to fight TB, malaria, HIV, USAID, they were always there. They helped us. They allocated funding so that we could equip our institutions. And we're talking about PPEs. We're talking about various small devices. Frontline responders, the people, our personnel, our medical personnel that worked in these COVID departments. And of course, here I'm not going to talk about. We had different devices, the equipment, artificial ventilation, oxygen concentrators, and cartridges, Gene Expert, and so we received last year about 12.5 cartridges for Gene Expert, and we're also using for diagnosis of the COVID. In parallel, understand that the pandemic is for a long time, at least the virus infection. So we'll try to change our operation.
Ослабить темп и не упустить, как говорится, из рук нить ситуации, контроль над ситуацией. И мы даже в тех первичных сетях, где открывались фильтры для, скажем, лихорадящих больных, для того, чтобы как можно раньше выявить больных с подозрением на коронавирусную инфекцию, мы там делали дополнительно, как говорится, включились наши врачи для того, чтобы отбирать среди таких пациентов, если отрицательный ПЦР, то, безусловно, делали Gene Expert, проверяли через рентгенограмму для того, чтобы сочетанные поражения не упустить. Если даже положительный ПЦР после рентгенограммы, после компьютерной томографии, если мы не видим кроме матового стекла, еще видим какие-то.
If we see infiltration and destruction, then definitely in parallel, Gene Expert is done for TB. I guess likewise, that was done in many countries. And of course, the primary activity was training, monitoring, and evaluation. And so seminars, meetings were conducted online over distance. And in this regard, the Global Fund grant and the infrastructure we managed to establish were quite helpful, because we managed to ensure a smooth transition to that mode. And I guess our TB service was one of the services that managed to finally end up with well-established procedures. And now almost each and every case of drug-resistant TB is discussed at the Republican level online. And respectively, the treatment regimen is selected given the individual DST data. And definitely, as for problematic issues, we understood the flow, the caseload was quite high, and when anti-COVID activities started, so mild forms were treated at home, and we could see that as a result, not only TB detection was affected, so detection of other diseases was deteriorated as well, and that's very typical of many other countries as well. And so as a result, bilateral processes could result in decomposition of lung tissues, and we could see that in many districts, screenings were delayed, and tuberculosis diagnosis again was affected, and the coverage rate dropped, and we could see the changes, negative changes, let's put it this way, and the negative effects in last year and this year. We are trying jointly with the Ministry of Health to maintain the situation as is in terms of diagnosis, so especially with a special focus on risk groups, and we can see that patients after coronavirus infection, they still have some residual changes, and secondary TB processes were detected in some of them. And I guess such patients will become our risk groups. Of course, in such settings where we have such restrictions as social distancing, visits to PHC network decreased, and as a result, we started active case detection. So we have the disease management program when mobile teams did active detection of TB among the population, and we also stepped in that process. So our outreach mobile teams could detect TB as a result of home visits. So tests could be conducted further. And as a result, we provided equipment as much as possible for that when it became possible after quarantine restrictions, so they could restore their pre-pandemic operations, and so they could start in the new reality. And the next problem is the risk of reduced effectiveness of treatment, both for susceptible and resistant TB, as I said before. Now, again, we are discussing the need to enhance outpatient treatment, so supervision, so we could ensure a maximum patient adherence. And of importance here is activity of outreach workers, and that's really helpful. So I will not take much of your time. And the next slide highlights the 4th International Conference on Integrated TB Control in Central Asia. That conference was conducted in the city of Astana in Kazakhstan. All recommendations are being implemented, more or less. And maybe something is not as expected, but as for political commitment, I guess it's available in all countries. So as for most efficient use of available financial resources, I guess that's in place. And as for ensuring universal access to competent services for prevention, early detection, and effective treatment, well, that's more okay. Especially, we need to highlight the services for people in the penitentiary center, people in risk groups, and then we need to improve access to services by enhancing the services at the primary healthcare level, and the services should be provided closer to patients' home. Border control, I've mentioned that before when I covered the laboratory part. I guess under the Global Fund project implemented by Project Hope, some good work was done, but it was not finalized. And so this is not the end. Memoranda were prepared among countries so we could share information on migrants, patients, cases, and now there is the same question. The laboratory services also need to exchange data on drug resistance, isolates, and so on. I guess this is needed. We need full-fledged sharing of data so patients could be safely transferred from one country to another. So migration processes could be taken into account in that context. And I guess we need to resume that activity with the governments, and the texts of memoranda are already available. And we need to make sure the memoranda are signed. I guess it will open up new horizons for our high-quality, effective cooperation among countries. So we mentioned new techniques, kind, genetics, and other. Even sequencing is performed now. And I guess in this context, in Central Asia countries, a lot of work is in progress ensuring support from partners, governments, and I guess the results are soon to come. And as for pharmacovigilance, it's become a routine practice. For example, let me say that our drug expertise center fully understands that those adverse events should be managed. And now we need to unify the relevant forms, and later on we have to consider integration of information systems. Definitely. As for training of pediatric TB, again, we are saying stepwise expansion and management of TB diagnostic and treatment services. So I guess such services and prevention will become more relevant soon. And so let me finish here. If you have questions, I will try to answer. So I'm sorry that was too fast, but that due to lack of time. I had to manage it over a short period of time. So, and I guess we have full understanding of the situation with HIV service, about sharing data, and it's being considered. And I guess we have to make sure it works as part of the daily routine. And then enjoying support from international partners. I guess some 7 operational studies are underway, covering various aspects of TB control. So this is it. Thank you very much for attention. Thank you so very much, Malik Moldabekovich.
Thank you, Malik, for this opportunity to learn Kazakh experience and for the update on the resolution of the previous conference. This will be taken into account when we will prepare the draft of resolution of this conference, and this will be disseminated. Thank you. Colleagues, now it's time for us to move to the results of the moderated sessions. The floor goes to the moderators of session number 1, complex approaches to identification of TB, Madam Makhaila and Mr. Paul.
Спасибо, Dilarom. Я бы хотела очень краткой презентации.
Thank you, Dilarom. I would like to make a short presentation to share the results of the first session. It's 1 slide per each speaker. I will start, and Paul will supplement and continue. The first presentation was made by the sub-regional WHO lab, Evgeny Sagalchik, and it was about the updated guidelines recommended by the WHO on Model 3 diagnostics. And I would like to highlight systematization of those new tests that this year have been approved. And I think this year was most fruitful year for diagnostic labs, where we got 4 new tests, and there are of medium level of complexity that we can introduce at the second level of labs. And I also would like to talk about long expected tests, which is expert MTB XDR. And Evgeny also talked about recommendations by the WHO about the diagnostic algorithms for these new tests. Basically, countries have so-called hints about what tests to introduce, and I think the work will become more interesting as far as diagnostics. Next speaker was from Uzbekistan, representative of USAID projects in Central Asia, and he talked about the interdisciplinary approaches to detect TB on pilot sites. The approach for me as a lab expert was very interesting. So it's a collective team approach. So how they work together and identified interesting target groups, and the working mode was very interesting. And the result, we can mention that during short period of time, from 1st May till 20th of August, the total number was to identify 19 TB cases. I think it's a good indicator. The next speaker is also has also covered laboratory work, identification and optimization of the transportation system to increase and detect TB and increase access to the service. What I can say is that use of GPS coordinates to prepare optimum routes between the points of collection of the samples from clinics to TB laboratory. And transportation twice a week, which is still continuing. And here we have also a result. So this year, in comparison with the 4th quarter of last year, basically we have collected twice more samples, and ERAS TB increased almost twice. That shows that this approach to transportation is very important. And as our speaker mentioned, this will be expanded and replicated in other regions, and hopefully this will be also copied by other countries around. Next speaker was Dilarom Mirova from Tajikistan. She talked about involvement of communities in identification of TB cases. Here she also talked about the mission of their work, which was strengthening of the local and regional capacity to improve the detection of TB and the drug-resistant TB. They also had so-called groups. Their target group was labor migrants, TB patients, and etc. And they have had very diverse approach. They've been training volunteers, and these volunteers then worked at the level of the communities. They helped and referred the cases to TB services. And that affected increasing detection rate. And in parallel, their work also helped to reduce stigma and discrimination. I also mentioned here that more than 95 foodstuff products have been distributed, 950 food sets have been distributed. The next was a presentation by Reshma Suresh about new technologies and artificial intellect used in combating TB. What I liked about this information was that portable small X-ray machines, which was really light and could be used by mobile teams and reach out to remote villages where even vehicles cannot pass. So a lab expert can take it manually on foot. And for instance, we can say that it could be done at the level of the villages. This new technology, within 1 second, conducts interpretation of the X-ray image and provides a report about the diagnostics. It was interesting in this presentation to learn about so-called web-based application, mobile application, which could be used at different levels, at the level of volunteers that detect cases, and further, clinicists and management. And by using this mobile application, we can send the images in the real time to the doctor and reduce time between diagnostics and start of treatment. And the last presentation was by Nikitina Tatiana from Uzbekistan, from the NGO, and she talked about her activity and how it affected the improvement of the TB detection. Now I'd like to give the floor to my colleague, moderator, Paul, and ask him to make some additions to my words. Please, Paul.
Thank you very much, Marka. I'm very grateful to you for making those full notes on all 6 speakers. I have just a few remarks to add. I was first of all very impressed by the presentations we had from Mirova Dilovan and Tatiana Nikitina, demonstrating the wide range of activities within which community groups and community volunteers were being used to support TB programs. I was then fascinated by the more technical presentations. The one by Reshma Suresh, like my co-moderator, I was particularly taken with the fact that artificial intelligence is now being linked with these game-changing handheld X-ray machines, so that the possibility of X-ray technology being taken out into the field become by all sorts of groups, supported, of course, by medical staff, becomes a reality. And also, I personally was fascinated by the earlier presentations on the use of on what is happening, the new tests that are coming in and expected, the new tests for TB, and the multidisciplinary approach to detection in Uzbekistan, and the use of transport for improvements for better specimen logistics. All of these made me feel very optimistic. And so I end this first day of the conference on a very positive note and hope that other participants do as well. Best wishes.
Спасибо большое.
Thank you. Do you have something to add, Paul?
No. I sort of had finished, and I'm expecting the chair to probably hand over to Dr. Partieva.
Yeah, thank you, Paul. Спасибо, Марко, спасибо, Paul.
Thank you, Marco. Thank you, Paul, for a very good detailed summary of the session number 1. And thanks to Marco for being able even to put together an entire PowerPoint presentation covering the results of your work.
I was especially impressed by that.
She's very productive.
And floor now goes to moderators of the second session, Mr. Dmitry Sinitsky and Begzat Taksambayeva, for a summary of the results of the section number 2 on improvement of detection and diagnostics of TB and drug-resistant TB. Por favor. Thank you very much, dear colleagues. I would like to make a conclusion of all the presentations. Unfortunately, I couldn't prepare an entire presentation quickly as Marta did, but I hope you will apologize to me. You will excuse me for that. So first presentation was about sequencing, introduction of new technology to the diagnostic algorithm of TB. And to tell about this in a few words, so now it's still quite expensive. We don't have enough trained staff. And there is a need to control the reagents and the purchase of the entire costly equipment. So why we do it? And if we talk about the results and about why we do that, whether we want it or not, this is a diagnostic of future. And if we want to jump on this train and reach the future, we need to start introducing new technologies, as well as train our staff that will tomorrow be able to start sequencing, not within 1 day or 2 days, but maybe 15 minutes. And this, of course, helps us to work with big volume of data that will open for us new opportunities in identifying the mechanisms of drug resistance and the treatment of TB. If you're interested in specific numbers, how much it is to introduce in Kazakhstan or Kyrgyzstan, please refer to Lale and Gulmira. I'm sure that they will be able to share this information and answer questions. Next presentation was on by Laziz from Uzbekistan, and he told us about 5 levels of diagnostics, which is currently used by Uzbekistan in diagnosing TB. And 2 main parts of his presentation talked about that they are now improving logistics in 4 regions of Uzbekistan, which are not fully covered by the opportunities of GeneXpert. Additionally, to the fact that now they work on the revolutionary technology to work with the samples of the serum, so they can do the GeneXpert XDI at the same time. So that's also an important part on introduction of new technologies. Additionally, we should also emphasize that first of all, lab in Uzbekistan, which is microscopic, drastically will be transferred to GeneXpert. Our third speaker from Kazakhstan, Lala Chingizova, talked about the importance of introducing the system of SNK, the management system and control, and shared the experience of Kazakhstan, where in 2020, NRL has had the external audit and received 75% of compliance to the standards of quality, which is very good. And the most important in this presentation
стандартным операционным процедурам. То есть вся эта работа наряду с работой в лаборатории.
So all this work along with the lab work it's focused on the successful identification of the TB. Next presentation has been made by Gul Jamal from Tajikistan, and she told us about that they have +9 machines of GeneXpert, and currently they have 56 units of GeneXpert devices, and they move from GeneXpert to GeneXpert Ultra. This has started in February 2020, and now they have 18 laboratories which are equipped with GeneXpert Ultra. And in 2022, they want to move all the other laboratories and resources to this technology. Difficulty in Tajikistan is related to human resources, but I think it's a common problem, and we talked about it too. The next brief was made by Begzat Osambayeva, and she talked about scientific test on drug resistance, which has been introduced since 2018-19 in Uzbekistan, Kazakhstan, and Tajikistan. And with new anti-TB drugs like pedaculin, galamanid, vinazalid, and cocozinid. Of course, problems have been voiced as well, along with developments. So the first challenge is obtaining pure substances, and as Begzat said, for instance, for galamanid, they have been waiting for 6 months and still were not able to get it for testing. The second important aspect is training of staff, and we have already talked and noticed that during pandemic, we had big problems with training, with attendance, meeting of trainers. Therefore, Begzat also demonstrated innovative method of online training right on the lab, not with the theoretical but practical, using action camera. And if you're interested and if you have problems with connection and work with colleagues, so please address to Begzat, and she will explain you in detail what is her system is. And of course, all these antibiotics and drugs are being introduced in Uzbekistan, Kazakhstan, Tajikistan, just like I mentioned before. And the last presentation was about laboratory practice in epidemiological control.
Just like within the activity of our TB labs, we may actually integrate to the surveillance in general. So that was quite a discussive session of ours. There were two important thoughts has been voiced, which could be part of the preamble of that document. So we propose to review the opportunity to introduce amendments to the legislation of the region to allow exchanging the TB isolates and sharing information. So the second comment was that it would be very good to have the external quality control. And Vladimir has mentioned that we actually were planning on doing that in Tajikistan, but based on the conditions which were not managed by us, like transportation was unable to be performed, so we were unable to perform. So, and dots and the exchange of those dots would be quite needed and important for all of us to share, and in order to integrate, to get integrated to the anti-terroristic, anti-TB approach globally. So should there be anyone to add on, Begzat? Well, thank you so very much, Dmitry. You've covered everything in order to improve the and to identify TB, including the MDR forms, and there were presentations by different aspects which were there to strengthen anti-TB labs and to provide quality lab diagnostics. Once again, I'd like to thank all the presenters, and I wish all the participants strong health and success. Thank you. Thank you all. Thank you very much, Dmitry and Begzat, for the given summary. It was very precise and specific, and for those who didn't have opportunity to take part during your session, this is my example. So a lot of interesting things I was able to gain from the summarizing reports. Colleagues, we are actually done with the presentations from sessions and discussions from the parallel sessions or satellite sessions. If you allow me, I'd like to also overview and to provide you with the summary of our first day. It was started and welcomed by Mrs. Parpieva, and she had a presentation on implementing national anti-TB program in the Republic of Uzbekistan, the achievements in this area, further observations, further objections. After Nargiz Nusratovna, we were able to listen to, there was this presentation of Dr. Askar Yildibayev, WHO Euro, with regard to the TB strategy all over the region. Yeah. And with regard to the progress made currently and those obligations which are being taken by the countries to achieve the strategies objectives focusing Central Asian region. At the same time, he has mentioned also the impact and complications and consequences of pandemic with regard to the global objective on combating on anti-TB activities. Then we've listened to Mr. Sevi Mahmedov, USAID, and he has shared with us the USAID Global TB Accelerator aims and objectives, and all the areas that are being supported by the government of US in strengthening combating TB globally, and in particular, he has mentioned also that number of memorandums of understanding has been signed in 4 out of 5 Central Asian countries. So 2 years ago, in different countries, within 1 year, within 2 years, this memorandums has been signed on behalf of the Ministries for Healthcare for those countries and by the USAID mission. Then Mr. Andrei Mashnaga, with regard to partnership Stop TB, has provided us with the information on the key lessons learned on the pandemic impact to all of us, challenges, and restoring anti-TB services to eradicate further TB. Supranational lab, Gautin Vladimir Antonenko, representing Gautin lab, he provided us with the information on global novelties, global updates in TB lab diagnostics, and also has provided us with the most recent data within the region. And in conclusion, Mr. Paul Sommerfeld and Yulia Kalancha, representing European Coalition on TB, has emphasized the role of civil society in supporting national programs on those underspent resources which are still there, on the capacity and potential which is covered by civil society and NGOs, and how in future we may attract them, we may invite them, not only for the treatment of TB, but also social support, social accompanying and preventive activities, and to involve them at the systemic level as well to support implementing anti-TB programs. So this is how we finished our plenary sessions. Then there was presentation of NTP managers of impact of COVID to TB control within Central Asian countries, Mr. Rajab Zoda, and the head of national program of Kyrgyzstan, Mr. Karatayev, Lamin Musaevich. That was after lunch. So, and that was the impact of pandemic of COVID-19 and the summary on achievements in achieving the items of resolution of the last conference. Then we were split into two parallel sessions, and just recently, quite successfully, we've got summaries from the moderators. And before that, before their summary, we've listened to another presentation from Mr. Adenov on the impact of COVID-19 in Kazakhstan, the experience of Kazakhstan, and those planned milestones with regard to implementation of last resolution after the fourth international conference. Well, ladies and gentlemen, if we do not have any questions in the chat, if we do not have any questions from the participants, okay, if all the answers has been given. So once again, I would like to thank all of you, all the participants. I would also like to thank our interpreters who were helping us to understand each other, communicate with each other, all the organizers of today's event, moderators, experts, presenters. Allow me to announce this day that we're done with this day, call it a day. So 8:30, we want to get back to our discussions. Thank you very much.